Alrighty, good afternoon. I'm Dr. Javed, and we'll be going over neonatology. Hopefully you filled your bellies up, but won't fall asleep in the next 3-4 hours. We have a lot of material to cover, but this should be a good comprehensive section. As you know, in the neonatal boards, and especially in the pediatric boards, there's a large component that is questions from neonatology. 1 in 4 questions almost come from neonatology when you think about the baby as a whole, all the parts from it, genetics, metabolism, etc. So we're going to go through a crash course of Neonatal 101. I will say that the first half of the material is a lot of maternal fetal medicine content, which we will fly through. A lot of this is important, but not heavily tested on the boards. The middle to the back half of the content is very heavily tested, and I want to spend some good time on that. So without further ado, I do teach with a lot of mnemonics. Okay, so I'm going to try to make this simple and easy and relevant for you. If it works for you, fantastic. If you're like, oh my God, I don't understand that, that's okay. That's totally okay. Everybody's a little bit different in the styles of how they learn, and so we want to make sure that you're comfortable, but I will show you a lot of different ways to learn this material. All right, so we're going to go through a ton of stuff, as you see, and we will try to hit all of these topics in as much detail as possible. And so let's, without further ado, so when we start with definitions, live birth, this is a complete expulsion or extraction that you have to have evidence of life. So heart beating and a respiratory pattern that exists. Fetal death is before the expulsion, so there's no evidence of life. It has happened in utero, and it had started at that point in time. Infant death then occurs right at the time of birth, all the way to the first year of life. So then we really talk in a lot of gestational ages. And so the gestational age is the number of weeks from the first day of the last normal period, and the birth weight is expressed in grams. We use grams or kilograms, not pounds or ounces in the NICU, in determining medication doses and determining modalities of respiration and in determining feedings. So there's 3 definitions or nomenclatures. One's AGA, appropriate for gestational age. This is usually between the 10th and the 90th percentile for any given gestational age. There are different types of growth curves that exist, and so there's some variation that happens of how they get plotted. But for the most part, between the 10th and 90th percentile is considered AGA. If you're SGA, your weight is below the 10th percentile, and LGA, large for gestational age, greater than 90th percentile. And these are some kind of breakdowns for that. And then even in the smaller size kids, we even further subdivide them into LBW, VLBW, and ELBW. So low birth weight, very low birth weight, and extremely low birth weight. And so these are the small gestations. Usually these kids kind of are between 22 to 32 weeks in that pattern. All right, so continuing on with definitions, preterm, these are infants that are born before the 37th week of gestation. The term infants are born between the first day of the 38th week up to the end of the last day of the 41st week. And there are some, you'll look in the literature, there are some discrepancies with exactly that, where it fits, but typically before 38 weeks is considered early. Term is 38 to 41-ish weeks, and then post-term beyond 42 weeks. So when we look at neonatal mortality, there are a lot of different factors that kind of play into that, and as you can see, race is probably one of the bigger factors. You have African American, which is an increase of deaths per 1,000 live births, and they have the highest mortality that exists. Hispanics would be right up there, Native Americans, Caucasians, Asians, and Pacific Islanders. A lot of risk factors that exist with that, so being a teenage mom, women that are greater than 40 years of age and have had no high school, unmarried moms, smokers, and then women with underlying disease. So if they have autoimmune disorders, any chronic illnesses, diabetes, cardiac illnesses, these would put them at higher risk to have a child that might have some complications. So the major risk factors would be congenital anomalies, prematurity, males more than females, and then multiples, usually within the second trimester. Congenital anomalies being the most major risk factor for neonatal mortality. So, what is the leading cause of neonatal death in the United States? A, neonatal sepsis, B, severe congenital anomalies, C, perinatal hypoxic ischemia, or D, premature birth. All right, severe congenital anomalies is correct. Is the leading cause of neonatal death. Premature births is a sub-portion within that. So the 30% that answered there are almost right, but the congenital anomalies is the correct answer. All right, so accounts for about 12% of all births. Let's talk a little about the preemies, but 65% of all infant complications and about 25% of all deaths. And so there are three primary kind of subclassifications of premature births. Those that are preterm labor, premature rupture of membrane, or the medically induced, be either maternal side or from the fetal side. And so risk factors for premature birth, if you've had prolonged premature rupture of membrane, chorioamnionitis, bacterial vaginosis, group B strep infection, pregnancy-related hypertension, placental bleeding, uterine anomalies, cocaine abuse, chronic disease, maternal BMI that is very elevated, or prior preterm birth, puts you at a higher risk of having another premature infant. Survival, if you look kind of globally, less than 1,500 gram infants, there's about an 85% survival. And if you look in the less than 500 gram infants, that's about your Coke cans, it's about the weight of that. That's 10 to 15% first-year survival if they are born into a level 3-4 NICU facility. Now, if you look at databases like the Vermont-Oxford Network, this database looks at about 1,500 hospitals across the world, and they break down their survival rate as such. Less than 23 weeks is about 30%, 23 weeks is about 40%, 24 weeks you get a really big jump to 78%, 25, 80%, 26 weeks, 85%, and 27 weeks, 89%. This is survival. This does not account for morbidity or complications from that. It's just that you are going to be alive. But I will tell you, 10 years ago, less than 23 weeks, that survival rate was only less than 10%. So we've gotten better at taking care of much, much smaller kids over time. So independent risk factors for increased mortality. And so this is a common board question they like to ask. So that at a higher risk of mortality would be being a male infant. If your 5-minute APGAR, not the 1, but the 5-minute APGAR is less than 4, if mom did not receive antenatal steroid prior to the delivery, persistent bradycardia at 5 minutes, hypothermia, intrauterine growth retardation, and where you are born at. And that's why there's a lot of a push with a lot of the perinatal centers to make sure that moms are getting adequate access to care. And kids that have the highest risk are born in facilities where they can kind of take care of those kids that have the highest risk. So IUGR, intrauterine growth retardation, so the risk factors from this are usually placental anomalies or placental abnormalities that are occurring. Remember, the placenta is attached up against that uterus, and so the nutrients that have to go in there have to be good. If you want to get a good idea how a baby is doing, you take a look at the umbilical cord. You get a nice, thick, fat cord, there's probably been a lot of nutrients that have been going to that infant over the period of time. If you get this scrawny, straw-like cord that's thin and kind of not making with the corkscrews, there's probably not been a lot of good nutrients that have been getting to that baby over the course of pregnancy. So placental abnormalities, maternal hypertension. Remember, if there's constriction of those vessels, and we'll go over this a little bit in more detail when I show you about the placenta, that constriction causes a restriction of blood flow, and that restriction of blood flow will limit the amount of nutrients that are going. Smoking or alcohol use, and malnutrition. So, you are notified that a newborn has just been added to your service. He was born 20 minutes ago via cesarean section at 37 and 4 weeks gestation for a repeat C-section at term. Why does this cause you to put the phone down and shake your head? A, your service is not on call. Screw that. B, he was not born at term. C, since he was born via C-section, he'll be in the hospital for 5 days. Or D, infants born via C-section have less complicated courses than those born vaginally. Lock your answers in. Please don't overthink this. Very good. He was not born at term. So because they're not born at term, they have a higher risk of having complications. Remember, most C-section kids are usually within the hospital 48 to 72 hours beyond. If you're holding them for 5 days, the insurance companies will kill you. And the D answer, infants born via cesarean section have less complicated courses. That's not necessarily true. The other caveats to remember from IUGR, just to kind of throw it in there, is that most kids, and this is usually when you want to affiliate or assimilate board questions together, on the boards, when they talk about IUGR kids, they're probably saying that the kid has had some sort of perinatal asphyxiation associated with it. Something went on in your utero. Either the kid had a difficult time tolerating labor, or this was often associated with a perinatal asphyxiation that occurred, okay? So babies that are born with moms that have chronic illness, remember, are going to have high risk of SGA. And SGA babies usually will end up catching up once they're removed from that restrictive environment. All right? Okay. The other thing about preterm and how NICU really kind of got its boon was back in 1963, President John F. Kennedy, he had a little baby, and in fact, 2 days from now, it'll be the anniversary of that baby. That baby was born on August 7th, 1963, and Patrick Kennedy was the baby's name, and Patrick was born prematurely. He was like 34, 35 weeks gestation, and was in the hospital. And Patrick had, at 34 weeks, what would you expect him to have? He had RDS. He had hyaline membrane disease. They didn't have surfactant back at the time, and so Patrick survived for about 5 or 6 days and then died. But because John F. Kennedy was who he was, it caught a lot of national attention, and the press really kind of jumped onto this story, like, how are babies like this dying because they can't get enough respiratory support? And just as what Sputnik did for the space age race, Patrick Kennedy did for the neonatal race. And so this caused a lot of people to get funding placed into neonatology, resources were provided, and I think there was a lot of efforts pushed that really kind of pushed the advancement of the field over the next 20 to 30 to 40 years. And so really, this really kind of started from John F. Kennedy's little guy. So what are we seeing now? That morbidity, now we're able to keep these kids alive. As you saw on the chart before, survival has gotten better and better and better. Now the challenge is how to, not only to keep them alive, but how do we get them with the least amount of morbidity possible? And so there are new challenges: chronic lung disease, retinopathy prematurity, intraventricular hemorrhage, necrotizing enterocolitis, and neurodevelopmental outcomes. And a lot of the efforts in NICUs today in this country and around the world is really targeting these factors and saying, how can we bring these complication rates down to get these kids to have the best outcomes neurodevelopmentally and medically possible? So it's important of recognizing the term late preterm. Back in like the mid-2000s, 2004 or 5, there was a lot of push around the country to really recognize that the population between 35 and 38 weeks, although they look mature, they may be acting more mature, they were very much a unique population, and they were at higher risk of having complications and issues than their term counterparts. And this is the late preterm child. And so in those late preterms, some of these kids had respiratory problems, some had feeding issues, a lot more issues with jaundice, temperature regulation, and some neurodevelopmental issues on top of that. All right, we're going to switch gears just a little bit and talk about the placenta. So remember day 6, the embryo kind of hits the blastocyst. So you have a zygote, the zygote becomes a blastula becomes a blastomere, and then that starts to divide. 2, 4, 6, 8, 16, 32 cells. Once it hits 32 cells, that becomes a morula, and then the morula kind of splits into an inner cell mass and an outer mass. That inner mass becomes kind of the embryo and the fetus. The outer really then becomes like the placenta and the trophoblast, and that trophoblast then splits into a syncytiotrophoblast or a cytotrophoblast. The syncytiotrophoblast makes the glycoprotein, and that's the beta-HCG that's made, and that helps stimulate progesterone, and then you have the chorionic villi that protrudes and then kind of locks in with the uterus. The fronds then allow for greater surface area, and so let me just kind of go through right here. So the trophoblast we talked about, the outer part of the trophoblast, so it directly contacts the maternal endometrium. The fetus, this is how they get their nutrients, and there's really no major histocompatibility antigens, and so thus it's not recognized as foreign. That's a good thing. We don't want the baby to be recognized as foreign in the mom, because the body will be like, okay, out you go, right? So this is kind of the cell stage cycle. As we talked about the zygote to the 2-cell to 4 to the morula, and as you can see down here, is you got your blastocyst, and then the syncytiotrophoblast, and as it invades the myometrium, then you start to get the fronds that appear over time. So the innermost surface is the amnion. This is the thick avascular layer, and the outer layer is the chorion, the vascular layer. And these are then organized into cotyledons, and you can kind of see these on the placenta. And each cotyledon has a tissue that is supplied by one artery and one vein. And so just like fingers, as you can imagine, as it invades through, each finger has an artery and a vein that goes in and exchanges nutrients and waste and such with the placenta to be given nutrients to the infant. So hemochorial, maternal blood directly contacts the fetal chorional tissue. So as you can see in the mature villi here, here's your mesoderm, here's your cytotrophoblast cell layer here, and this is kind of the fronds that kind of come in there and start to invade into the intervillous space. And you have the fetal capillaries, ones that come into the umbilical cord and one that's coming from the umbilical cord. And so as they come through, blood goes to the mom. It's low in oxygen, nutrients, and high in carbon dioxide waste. And then blood from the mom is high in oxygen, high in nutrients, low in carbon dioxide waste. Because remember, the infant's not going to be using its lungs. Everything has to kind of help in circulation through the mom's side. So you have a low resistance circuit that allows blood to kind of passively go back and forth very easily. By having like a finger-like approach into that, you have increased surface area. Imagine if you just had one big like stalk that went in there, you just have the outside. But if you split your fingers apart, every single surface area is going to be in contact and interaction. So you've now multiplied your surface area by almost 5, 10, 50-fold if you multiply by the number of fronds that are necessary for that interactive space. All right, the umbilical cord. Average length of an umbilical cord is about 50 to 60 centimeters. If it's less than 30, usually they have a poorer outcome. Everybody talks about the two arteries in one vein that makes more like a smiley face. I kind of like think about it in the emoji world. It looks more like the wow emoji, you know. So you have the two eyes and kind of the O that makes the vein. Remember, the arteries are a little bit more stiff in its structure. The vein is very floppy and bendable, and so the umbilical cord is covered by amnion. It spirals. It's a spiral cord, and it usually spirals in a counterclockwise direction. All right. Sometimes you may see a single umbilical artery, and this happens in about 0.5 to 1% of all births. If you do see that, think congenital anomaly. Think trisomies. That might be causing that. It is a common malformation that's seen. It's more common in in twins than it is in singletons. And usually if you have a single, there was a lot of talk about there could be urogenital anomalies, renal anomalies that might be associated if you just saw a single umbilical cord. The most common, trisomy 18, will have single arteries. So renal, cardiac, trisomy 18, and more common in twins. Placental anomalies, chorioamnionitis, this has kind of undergone a transformation in terminology. There's some intrauterine inflammation and infection, or what they call the triple I. All right, so usually it's fever plus something, fever plus tachycardia, maternal WBC count, purulent fluid from the cervical os, biochemical or microbiological amniotic fluid consistent with an invasion of the amniotic cavity. Then you have invasions. So you have accretas, you have percretas, and so this is where the placenta kind of invades or embeds within the uterine wall. Remember, the accreta, as you can see, is kind of starting to embed within. You see these most commonly in moms that might have had an IUD placed, which increases the risk. The percretas kind of go through and through, and they can cause extension, go towards the bladder usually. And it's just a penetration of the placenta through the myometrium. These are all high risks of bleeds, and there's an increased risk at the C-section time that moms can have quite a bit of hemorrhage for these, and so that's why it's really important, especially as you try to remove the contents of the placenta that is embedded within the uterus. It can cause a lot of problems of retained placenta and cause ongoing issues to the mom. All right, so major risk of maternal hemorrhage, as we mentioned. Abruption or abruptio placentae, it's the retroplacental hemorrhage. This is mom's blood, okay? And this is the problem. Remember, as that placenta is attached to the uterus, nutrients are going well, okay? And the minute you start to get some tear or a pull apart, now time's a ticking, okay? So as that goes, this kid can be at tremendous amount of risk because that is lack of oxygen and nutrients that are going to the baby. And if it's a lot of vessels that are sheared, then over time you're talking about a emergency C-section that is necessary to get that baby into a safe environment again. So, when they talk about cervical abruptio placentae, there has been a tear from that, and that means that baby's not getting oxygen. Okay, and so just as if we were to be submerged underwater 20, 40 seconds, a minute, minute and a half, that time's a ticking before that oxygen is not gone to the brain and can cause long-term issues. Chorangiomas, these are benign placental tumors. They're small in size, usually asymptomatic. They can cause fetal cardiac failure and hydrops. Usually they are formed within the second trimester. The large ones will have these complications of the hydrops and the cardiac failure and hemolytic anemia, cardiomegaly, IUGR, low platelet counts, etc. And so thankfully we don't see a lot of the large ones, but you may see small ones, and usually those are pretty benign. All right, twins. So the thing you need to know about twins is to remember two parts. One, it's usually defined as chorionic and amniotic, so di or monochorionic, and di and monoamniotic. So chorionic refers usually to the placenta, how many placentas there are, and amniotic usually refers to how many sacs exist. Okay, so think about it in that way. When they say chorionic, how many placentas, and amniotic, how many sacs. And when twinning occurs, really kind of determines when it happens. If you're di-di or mono-di or mono-mono or conjoined, really kind of depends when the cleavage occurred. Now I'm going to teach you a really kind of dumb way to remember this, but it will stick with you. All right, so think about when you first start off, you're in high school, you really don't know anything, so you're like, duh, and you're like, duh, all right? So diamniotic, dichorionic. So this happens in the early part, in the first 1 to 3 days, all right? Then you become enlightened, and you go and become a doctor. You have an MD degree, so you're mono-di, all right? So this happens in the 4th to 8th, so you're then you become enlightened, you're mono-di. Once you're a doctor, then you have to start doing M&Ms, or morbidity and mortality reviews. They're really boring. But M&Ms happen next, so mono-mono, and that happens in that first week, day 8 to 13. And then once you start doing M&Ms, you realize all the things you did right and all the things you didn't do right, and you become confused. And that's conjoined, all right? So now you're at the end of your stage at day 13 to 15, and you're confused or conjoined. So then you become a doc, MD, so monochorionic, diamniotic. Then you have to do M&Ms, monochorionic, monoamniotic, and then you become confused or conjoined, okay? Not that this is how it happens, but this is how you're going to remember it, all right? All right, so just a couple of other key features. The mono-di, these are the most common type of monozygotic twins. They have a high risk of twin-twin transfusion syndrome that happens. And the mono-monos, they're a high risk, as you can imagine, being in one sac, high risk of cord entanglement in those kids, okay? All right, so monozygotic identical twins, most commonly mono-di, as we just said, share the same amniotic sac, highest risk of cord, and rarely dichorionic. And dizygotic fraternal twins, diamniotic, dichorionic. All right, twin-twin transfusion. 10 to 15% of the monochorionic twins have twin-twin transfusion. One twin's artery supplies its cotyledons drained by the second twin's vein, is usually what happens. So you have a vascular anastomosis that is occurring, and so the donor twin, the twin that is getting everything taken, they become anemic and oliguric, and they become what's called a stuck twin, okay? So there's like less fluid around them. They're kind of like getting all their nutrients taken out of their body. The recipient twin is like loving it. They're like getting all this extra blood. They're like stretching out. And so the recipient twin gets larger, gets more space, polycythemic, hydrops, heart failure. So which twin do you think does well afterwards? So usually the donor twin does really well post-delivery because they've been already scrawning at it and trying to figure out and make things happen. The recipient twin was loving life. Now they don't know how to do anything for themselves, and so when they come out, they usually have a lot of issues, and they usually struggle. And so there's a lot of prenatal surgeries that occur now. They look at antenatal laser ablation to really kind of go in there and try to resect some of the vessels to prevent a significant amount of twin-twin transfusion from occurring, monitor the amount of growths, and if it becomes really, really discordant or twins at risk, they try to deliver the infants. All right, so prenatal care, we're going to kind of go through this, what to expect. So like a lot of the dating that happens, and it happens by the first day of the last menstrual period, H&P exam, you have some antenatal labs that you do, blood counts, infection, torch workup, blood type, RH, and Coombs, and then some counseling. A lot of visits, as you know, when you're expecting. You have the first visit at about 6 to 8 weeks. Most moms don't even know that they're pregnant by 6 to 8 weeks. So 10 to 14 weeks, you start to hear the fetal heart tones. By 16 to 20 weeks, repeat labs and check for any abnormalities. And then they do the alpha fetal protein test, and we'll talk about the AFP in just a second. The 22 to 26 weeks, routine care. 28 weeks, we'll do the glucose tolerance test and check for RH immunoglobulin as indicated. So if they need RhoGAM at that point in time, they'll give. And then 32 to 36 weeks, routine care until delivery has to happen. All right? So ultrasound is usually kind of subdivided into a couple different types of ultrasound. We do a dating or a very specific anatomy ultrasound, which is called a level 2 ultrasound that happens at about 20 weeks gestation. Quad screenings at 15 to 20 weeks. So let's talk about the alpha fetal protein. So AFP is really an early part of the gestation. It comes from yolk sac, fetal yolk sac. In the later part of gestation, it comes from the liver and GI tract. And really, it passes from the fetal serum and goes to the fetal urine and into the amniotic fluid. And following, the glycoprotein is then surrounded and catabolized by the GI tract. Now, one of the things they love to test is if you have high alpha fetoprotein or low alpha fetoprotein. And so the way I would remember it is that if you imagine elevated alpha fetoprotein, think about an arrow that's pointing up. And just as this umbrella is showing, if you have an arrow pointing, it looks like an arrow pointing up, and use umbrella when it rains, RAIN. And so these are the things that will cause elevated alpha fetoprotein, renal agenesis or polycystic kidney disease, A for abdominal wall defects, I for incorrect dating or multiples, and N, neural tube defects, RAIN. You can also see in cystic hygromas, sacrococcygeal teratomas, but if you imagine the arrow pointing up, and that arrow's top looks like an umbrella protecting you from the rain. On the other side, if the alpha fetoprotein is low and it's going down, the arrow is going down, you're at high risk of Down syndrome. So trisomy 21, trisomy 18, or overestimation of the gestational age. Okay? So this is up, the down is in the opposite. The other things that you want to look at estriol, it's the hormone made by the placenta and the fetal liver. So if you just think about trisomy 21 and 18, and to differentiate the two, alpha fetoprotein are both going down. In trisomy 21, the beta HCG is elevated, and the beta HCG in trisomy 18 is down, and estriol are both going down. So you have low estriol, you have low alpha fetoprotein, but the beta HCG are going to be the one differentiating factor between the two. Okay? All right. Group B strep. We're going to go a little bit more detail of Group B strep in a little bit, but it's the leading cause of neonatal bacterial infection, 4 in 10,000. Used to be 15 in about 10,000. 75% of all GBS in rate, is term gestation. There's been no change in rate maternal colonization, and they do the culture and screen usually at about 35 to 37 weeks. That's a vaginal and a rectal culture that is done. So prophylaxis for all positives, GBS bacteria during current pregnancy. A lot of risk if you have a prior infant with a GBS infection. If it's unknown, if the infant's less than 37 weeks gestation, interpartum fever, rupture of membrane greater than 18 hours, or interpartum antibiotics, these are the things that you're going to want to consider. So which antibiotic to use for prophylaxis? So penicillin or ampicillin, there's really no reported resistance. If you have a penicillin allergy, you can use cefazolin. The high risks, also known for like clindamycin, erythromycin is sometimes used, but this doesn't really kind of replace the use of any penicillin-based product for this. So which things do not require prophylaxis? Colonization of GBS in a previous pregnancy, GBS bacteria in a previous pregnancy. So whatever's current will only mean what you need for this particular pregnancy. C-section before the onset of labor and negative vaginal or rectal GBS screening in the last 5 weeks. If you don't have a culture, then you have to kind of figure out if you have enough risk factors that indicate that you really need prophylactic treatment. So less than 37 weeks gestation, rupture of membrane greater than 18 hours, or high fever. And so there's an algorithm that that is put out that you can find on, there's apps for it to look at GBS algorithms to determine what you need to do. And I would try to become familiar with this. So, the question that you start off with is, does my infant have sepsis signs? If yes, then you do the full court press. You do the full diagnostic evaluation, CBC, blood culture, urine, plus or minus a tap if you need it, and start antibiotics. But if it's no, then it becomes a little bit more muddled. So then you ask, does mom have chorioamnionitis? Does mom have chorioamnionitis? And so chorioamnionitis is very difficult to determine. Back in the day, a placenta would deliver, and they was like, oh man, that smell is horrible. I think that mom really had choreo there. And then we'd start doing like a lumbar puncture and everything else. And now you almost need other factors. You need to have a maternal fever, elevated white count. You need to have more determination. And a lot of times that placenta will get sent to pathology to see if there's true choreo that exists. If you have a good confirmative case of choreo, then you might want to do antibiotics and a limited evaluation. But if they don't, then you have to ask, was mom given proper GBS prophylaxis? What does that mean? Did they get some sort of penicillin-based agent greater than 4 hours prior to delivery? So greater than 4 hours prior, was there a penicillin-based? If it was Clinda, if it's erythromycin, that doesn't count. It has to be a penicillin-based agent. If it's yes, was there an indication? There's no indication, no evaluation further needed. If there was an indication, then you have to determine how is my gestation age of my infant. Greater than 37 weeks, less than 37 weeks. How long was the membranes ruptured? And kind of work through this pathway to see. And now so much so, because of the antibiotic stewardship that occurs, we do a lot more observation if the kid is asymptomatic and watch, rather than starting antibiotics and putting them and subjecting them to the exposure of antibiotics. All right. An expectant mom in your practice has previously delivered an infant whose postnatal course was complicated by GBS sepsis. She wonders if there's anything that can be done to lessen the chances of this occurring for this pregnancy. You tell her which of the following. A, she will be cultured before delivery, and prophylactic antibiotics will be given depending on culture results. B, unfortunately, there's no way to lessen the chances that this infant will be infected. C, she will receive intrapartum prophylaxis on the basis of her history. Or D, depending on the sensitivity of the previous infant's group B strep, she may be able to receive intrapartum prophylaxis. Five seconds. Ooh, okay, so she will receive intrapartum prophylaxis on the basis of her history. Now remember, this is an expectant mom. It doesn't matter what she previously delivered. She had a risk of GBS sepsis, but she's going to go through the routine basis here. The question, you tell her which of the following, and I think the concern is between A and C. She'll be cultured before delivery, and prophylactic antibiotics will be given depending on culture results. The part of this question that really has to kind of be looked at is that she's an expectant mom. She's previously delivered an infant whose postnatal course was complicated by GBS sepsis. This wasn't happened in the utero and then had issues. And so the routine culture will be there, but based on just routine history, she had a kid who already had a high risk. She's going to get antibiotics to protect her. All right, preterm labor. Uterine contraction with cervical changes at less than 37 weeks gestation are going to put you at higher risk. Prior preterm birth increases the risk, and steroids. So the risk of, if you're going to have preterm labor, there's probably a higher risk of that you're going to need to have steroids to help get that baby ready. So ACOG has a consensus that less than 34 weeks gestation, mom should receive an antenatal course of steroids. Remember, the steroid starts to kickstart the body's process so that the child is going to be ready. Now, usually when mom's going in preterm labor, there's something going on. Either baby's not in distress or mom's having preeclampsia and she's in distress, regardless of which, that starts to trigger, hopefully, some of the mechanisms to the baby to say, hey, this is not going to be our environment for very long. We got to get ready to get out of here. And we need to be ready. And in order to be ready, your lungs have to be mature and developed. Your brain needs to be kind of ready to go. And so the body starts to kick its own natural catecholamines in place to get. Now, if it's a baby-induced stress, usually the baby-induced stress has already kind of got going, and the baby's own innate catecholamine response will kick in, and babies are going full force ahead. But if mom has not had a chronic illness and suddenly starts to have blood pressure changes, and it's very acute, where she's going into eclampsia, for instance, then the kid may not have had an opportunity to start to build their own steroid response. And having this antenatal steroids given really kind of helps augment their natural steroid response to get them going. Membrane rupture prior to onset of contractions, expectant versus active management based on estimated gestational age. Usually, if they're really, really young still, you might decide to have a watch and wait approach to make sure that mom is not in trouble and baby's not in trouble. We'll put you on bed rest and we'll just kind of slowly progress along the way. But if any party gets in trouble, then we will move forward and have to deliver to protect and be safe on either side. All right. So preeclampsia. So you want to measure blood pressure and the urine protein in the second or third trimester. It's categorized by many symptoms or signs: systolic blood pressure that's elevated, proteinuria greater than 5 grams in a 24-hour period, oliguria, visual or mental status changes, epigastric pain, pulmonary edema, and then there's HELP syndrome. So hemolytic, elevated liver enzymes, and low platelets. So that HELP syndrome is kind of more of a further stage along the way. Management, kind of straightforward, either labetalol or hydralazine. You may use the mag sulfate for blood pressure and to try to prevent seizures, as we mentioned about the HELP syndrome. And as you can see in the image down here, you have normal maternal blood flow. With that elevated pressures, you're squeezing and restricting the amount of flow that is going through, and that restriction of flow is not allowing more nutrients to go to the baby. Baby starts to get in distress, okay? And over a period of time, depending on how chronic the high blood pressure may have been or how long that difficulty may have lasted, over a period of time, that is restriction of flow going to the baby, and that restriction of flow means that there's less nutrients, and that kid's going to be at higher risk of having growth delays. All right, we'll briefly touch about maternal diabetes mellitus, so this increased rate of congenital anomalies related to the preconception glucose. So how well controlled the mom was prior to delivery or prior to pregnancy will kind of determine how bad the glucose might be in the baby. So issues with macrosomia, remember that, so glucose kind of transfers over through the umbilical cord from mom to baby, but mom's insulin doesn't transfer over. So what happens to the baby is the baby's pancreas starts to work overtime. You see all this excess amount of glucose in there. It's like, whoa. And so the insulin starts to work overtime, and it's starting to combat and kind of keep things under control. And then all of a sudden you cut the cord, and the glucose is gone. But the insulin has been already working overtime, and so you got a sudden drop-off, and you have these hypoglycemia that occurs in the baby. So hypoglycemia, high glucose, risk of respiratory distress syndrome, cardiomyopathy, and jaundice. And we'll go through more glucose and glucose pathophysiology a little bit later. Fetal well-being, you monitor the growth, the fundal height. Right around your belly button is about 20 weeks gestation. And as you kind of get so you're measuring from the pubic symphysis up to the umbilicus, and that kind of gives you an idea of what the mom's carrying size is. It'll be increased in polyhydramnios and decreased if then you evaluate for IUGR. This is kind of a very crude way of assessing mom-baby, but kind of gives you a little bit of an idea. And then right up to about the xiphoid process, as you start to feel that fundal height, you're getting closer and closer to the term infant. Well-being ultrasounds, remember we talked about level 1 and level 2. So level 1 ultrasounds are more of your screening ultrasound, and then the level 2 ultrasounds more of the anatomy. You're looking a lot of factors within the ultrasound. So they look at the biparietal diameter of the head, abdominal circumference, head circumference, femur length, to really kind of determine what the gestational age is of the baby and how the baby is doing. They also do different types of tests, NSTs and CSTs, so non-stress tests. Remember, the non-stress test has two parts to it. It's the fetal movement and the heart rate. Okay, so you're looking at fetal autonomic activity when you're doing the non-stress test, and really kind of assesses the fetal well-being. All right, the contraction stress test is heart rate plus contractions, interestingly. So it's the contraction stress test, and it's really to assess if there's any uteroplacental insufficiency that is there. Is the baby going to get in trouble when contractions start? And really kind of will help determine tolerance of labor. So the non-stress test is to determine fetal well-being assessments, and the contraction stress test is to see how well the fetus is going to tolerate labor. And there's some definitions here. Again, I wouldn't get yourself too wired into all this. It probably will not be tested on your pediatric boards, probably more so on the neonatal boards. The biophysical profile then is the BPP. It's taking the non-stress test and a component of tone and a component of the amniotic fluid index. So it's the NST plus the tone of the baby plus an AFI, and kind of depending on the score there, we'll kind of risk or alert the physician to say, hey, I think the baby's at risk. You need an intervention and deliver sooner. And usually that's sort of scores that are less than 4, or you can kind of continue to monitor the infant. And so here's kind of the scoring pattern for the NST. See if there's acceleration, breathing, movement, tone, and the amniotic fluid index. Less than 0 to 2, deliver. 2 to 4 is where you really got to be very, very careful. 8 to 10, you just kind of continue to repeat in a week's time. There's now a modified BPP that divides the amniotic fluid portion into different quadrants to really kind of determine a little bit more specifically if the baby's at risk. Fetal heart rate monitoring. So this is a simultaneous measure of fetal heart rate and contractions. We want to see good beat-to-beat or saltatory variability in the baby. It's usually measured externally or internally. Remember, if they put the internal probe on, they usually kind of corkscrew it into the scalp. Be very careful when you take it out. You don't want to rip that off the scalp, and you got to unscrew it. Internal direct fetal scalp electrode with a transduced amniotic catheter, and you get auscultation. And so you want to put fetal heart rate monitoring in a lot of their high-risk pregnancies. So here's some of the heart rate patterns. Normal beat-to-beat variability. Heart rate's usually about 120 to 160 beats per minute. You get a non-reassuring fetal heart tone if you get a lot of tachycardia, bradycardia. If there's not enough variability beat-to-beat that is there. And then we start to then determine, as contractions are occurring versus the heart rate, when are those in correlative sync with each other? And that may give you a sign of early deceleration, variable deceleration, or late decelerations. So lates are really ominous. There's no beat-to-beat variability that exists. Other ominous patterns would be prolonged severe bradycardia. If you have a sinusoidal pattern, if baby's not sleeping, meds, early preterm, there'll be a loss of beat-to-beat variability that's there. So if it's non-reassuring, you can do a fetal scalp stimulation and determine what the scalp pH is. If it's less than 7.2, you probably want to get that baby out. If it's greater than 7.25, you're okay. If you're at any risk or you worry about acidosis in a baby, you need to deliver at that point. So the fetal heart rate patterns are really kind of helping determining. Sometimes in deliveries, you'll see that the infants were delivered because of NR-FHT, non-reassuring fetal heart tones. And so those are the times when you want to really kind of push forward ahead of getting delivery. Severe bradycardia, you'll see in prolonged cord compression and prolapse, tetanic uterine contractions, paracervical blocks, maternal seizures, or rapid descent in the birth canal. This can be very scary, both for OB and for family. So let's talk about decelerations. There's early, late, and variable. So the early decels kind of mirror. As the contraction occurs, the heart rate will kind of drop at the same time. And so it almost looks like a mirror pattern as you're kind of watching it on the wave. And so this is usually because the head is compressed within the area. You have variable decels. And this is probably cord compression that is ongoing. And then there's late. So usually as the contraction happens and it starts to relieve itself, then the heart rate starts to drop. And those are more scary because the lates probably mean there's some uteroplacental insufficiency that's ongoing. And so you really want to make a good assessment to make sure that the infant is not acidotic and having issues. So here's early decels, as you can see the mirror. So heart rate starts to come down, mom's contractions happen, and then as mom's contractions abate, fetal heart rate tones start to go back. So probably from head compression. These are the lates. So as you can see, the contraction occurring, and once that contraction starts to decrease, then the heart rate starts to go down right about that time. So those are more concerning for uteroplacental insufficiency. All right, so cesarean section, indication, if you had a repeat C-section, we try not to, I know that the OBs try to push for vaginal birth after cesareans. A lot of physicians will be very cautious, and even though there's a good success rate for VBACs, there's also a lot of risk. And I guess in my line of work as a neonatologist, we see the complications that occur, and so we'd never advise even our own loved ones to go through VBACs. Malpresentation, usually breech, so there's a frank breech that's here, where the butt's kind of stuck in, and you have extension of the legs and flexion at the arms. You have a complete breech, both flexion at the knees and at the arms, and then footling. Shoulder dystocias or cervical dystocias, you got to be very careful because you want to pull at the neck and cause issues. And if their fetal is in distress and you need to get the baby out, then you got to get the baby out. The cesarean section rate in the United States is about 30%. About 60% of these are from very premature births. It does cost more because it's a cost not only to have the cesarean section, but then the postoperative care. Mom's going to be in the hospital for a few more days. It is a major surgery, and I think we forget about that. A lot of times we do a cesarean section, and there's a baby that comes out of it, and you're like, oh, baby. Forget that mom went through just massive surgery on her belly. And so, we have to kind of take that into mind when we are talking to moms, that they just are postoperative and have gone through quite an experience. It does increase risk of maternal morbidity over time. So we talked about a little bit about VBAC, success rates as high as 68%, but those extra 20% that are not successful can be very devastating. Operative vaginal deliveries, these are still occur in operating rooms as trying to get the kids out. So vacuum extractions or vacuum deliveries, usually they try not to do more than 3 attempts. If you're the provider there, it's hard to tell the OB, hey, 3 has been enough. You put the kids at really a lot of molding, a lot of bleeds. Subgaleal bleeds are one of the biggest complications for these, and they can bleed quite a bit into their brain space. Forceps assisted, I have seen less and less of these, thankfully. Those are really brutal, especially how it grabs onto the head to take out. A lot of facial nerve injuries and palsies that have occurred to the infant, and just the high risk of malpractice that is there. Traumas, bruising or skin lacerations. When you go to do the C-section, if they cut through the uterus too deeply, a lot of lacerations around the forehead, over the eyelid, over the face can occur. Subgaleal hematomas and cranial fractures. So operative delivery, this is kind of how the baby is positioned in relation to the mom's pelvis. All right, so we're going to switch gears a little bit and move to fetal circulation. All right, so fetal circulation, there's 3 natural shunts that occur: the ductus venosus, the foramen ovale, and the ductus arteriosus. So this is when you hear the PDA, the patent ductus arteriosus, and the PDV, the patent ductus venosus, and the foramen ovale. And so those 3 natural shunts exist naturally, because remember, as blood comes from mom to the baby, it comes to the heart, gets into the right side of the heart, and then just shunts across. Well, very little goes into the lungs to get anything, because the baby's lungs are filled with fluid. It comes across, and then it shoots out to the rest of the body and does what it needs to do. So in normal transition circulation, your pulmonary artery pressures, once after birth and the baby cries for the first time, those pulmonary pressures should drop. At the same time, as the pulmonary pressures drop and all the fluid is evacuated from the lungs, the blood flow starts to pick up and the oxygen tension starts to increase. So that what happens is that the systemic circulation starts to increase in pressure and the pulmonary circulation or pulmonary pressures start to decrease, because we want blood then to go to the right side of the heart from the right ventricle into the pulmonary artery. We want that to preferentially go into the lungs to get oxygen. If the pressure is too tight in the lungs, it's going to be hitting like a brick wall. And so it's going to say, forget this. I'm going to go back to a system that was most comfortable to me, persistent fetal circulation. And so they transition back and they get those shuntings. Those 3 natural shunts that exist will want to go back that way, and that's where pulmonary hypertension's early beginnings occur at. So here's that PPHN. And so here, remember our diagram, this is normal. And now what's happening is that the pulmonary arteries are not getting a chance to relax. The blood flow is not going through there, and the oxygen tension stays really, really low. And so you get a system where the pulmonary pressures are too high. And so deoxygenated blood, because now the cord is cut, deoxygenated blood is entering into the right side system, and deoxygenated blood is getting shunted to the left side and getting to the tissues, so there's not enough going there. And so what happens is the body then starts to clamp down further, and the baby goes into a cycle of severe pulmonary hypertension. All right, so fetal transition. The fetal lung is fluid-filled. It's lung liquid, not amniotic fluid, and it's critical to normal lung growth. Transitions to air-filled versus liquid begins during labor. So those cardinal movements of labor that occurs to get the baby prepared, that also kind of gets the catecholamines upregulated and said, whoa, we're going to be going out soon. And so let's get our body ready so that at the time of birth, within that first cry, so much fluid can get shifted over to allow that fluid to be removed and for air to get filled into the lungs. So there's a reversal fluid movement, down regulating of the chloride channels and up regulating of the sodium channels. And then surfactant, which we'll talk about a little bit later, they're made and stored from type 2 pneumocytes, tenfold higher than the adult lung, and massive release within the first breath. This decreases that surface tension and avoids that end expiratory collapse. So that first breath requires intact CNS system, critical to circulatory transition, and typically high inspiratory and expiratory pressures, a prolonged inspiration effort of 1 to 3 seconds. And the idea is to displace the lung fluid, establish air volume in the lung, release the surfactant, and decrease the pulmonary vascular resistance. So babies do this in a variety of mechanisms. They'll cry. If they are really trying to get that increase of air, they'll grunt. So you'll hear that, and that's that sudden intrathoracic flow, or they'll nasal flare. They'll get their nostrils really, really big to allow sudden rush of air in and to allow that air to get into those distal alveoli to pop those open. Other parts of fetal transition is glucose, and so fetal glucose is derived entirely from the mom, as we talked about, through the GLUT1 receptor. As the cord is clamped, now the baby is responsible for glycogenolysis and gluconeogenesis, which of all of this is which is really important for the baby because that's what their brain exclusively relies upon. They don't go through ketone bodies, they don't go through any other way, they have to use glucose, and hence that's really important. And we'll go through glucose metabolism in a little bit more detail. Water balance. Term infants is 80% water. A third of that is extracellular fluid. 8 to 10% loss in weight in that first week. So remember, total body water will decrease, all right? Intracellular water will increase, and extracellular fluid decreases, all right? So you get TIE. You're going to tie this all together, TIE. So the first is tie for the T, total body water coming down. And for I to come, I has to start from low and go up to the middle to be TI, and then E, extracellular, comes down. So TIE. So I'm going to tie it together. So total body water down, extracellular fluid is down, and intracellular is the only one that's increasing. All right. Fetal circulation is characterized by A, high left ventricular output, B, pulmonary hypertension, C, similar anatomy to that of newborns, or D, separation of the right and left-sided circulatory systems. Pulmonary hypertension, yep. So it's very similar to the pulmonary hypertension as we talked about. So you have like the increased amount of pressure within the lungs. Remember, it's a low resistance. The only difference between fetal circulation and once they're born is that in fetal circulation, they're still attached to their mom. And so when they have the umbilical cord attached still, the blood flow still goes through, the oxygen still goes through. You have oxygenated blood that is coming to the right side of the system, whereas once the cord is cut, you have deoxygenated blood coming to the right side of the heart, and going through the system. All right. Virginia Apgar. So this is a lady who has had a profound impact on pediatrics and neonatology, yet she wasn't a pediatrician. She was an anesthesiologist, of all things. So she created the Apgar score. And so if anybody who's ever had a baby, the first thing that parents will ask is, what was the Apgar? I don't know what they get out of that. What was the Apgars of my child? So it's a scoring from 0 to 10. It looks at 5 different factors: heart rate, respiratory effort, muscle tone, grimace or reflex irritability, and color. Typically, the scores are designed when they put these together for term infants. Yet we use it for all of our infants. And even though it goes up to 10, you rarely see anybody score a 10 because it's considered superstitious not to score a kid. Usually that kid will end up in the NICU if they get a 10. So we score usually a 9 in those. All right. So reflex irritability is tested in response to a catheter placed in the infant's nose. Scoring is done at 1 and 5 minutes. If the score is less than 7, then we'll get a 10-minute and maybe a 15-minute and maybe a 20-minute. The maximum score, as I said, is you get a 10. Now, the big thing is, do you wait to see what the 1-minute Apgar score is before you determine what you're going to do with the child? Absolutely not. Usually we're trying to figure it out after the fact, but you're not going to say, whoa, it's been only 15 seconds. I can't do anything yet. Baby's not breathing. Oh, 30 seconds. Oh, it's 45? Okay, 5, 4, 3, 2. Okay, a minute. Now now you're not breathing. You got an Apgar of 1. We better do something now. No, that's not how it's going to happen. All right, so it's a tool to assess transition. It's useful to target resuscitative efforts. It does not predict cerebral palsy. And Apgar scores, as I mentioned, is only designed for term infants. So I find it very hilarious when really premature infants are scoring 8s and 9s in them when their tone is kind of floppy to begin with. And that's a normal tone for a 25-weeker, but they get scored a 2. And they sure as heck don't have, color in every way, but they get scored a 2. And so it always amuses me when I get an infant who has a Apgar score that's like a 24-weeker of 9 and 9. I was like, that's some great resuscitation that you did there. All right, so cyanotic heart rate, so greater than 100, breathing, so a little bit of NERP. Free flow oxygen starting at 30%. This has more been adjusted to 21% now. Where you're going to start resuscitation, and then if necessary, you turn up because we find and we know that oxygen is not benign. If the heart rate's less than 100 and the infant, you want to see for breathing, look for chest wall rise, but if you have a heart rate less than 100, we start positive pressure ventilation, and it's that breathe 2, 3, breathe 2, 3, breathe 2, 3 kind of cadence. And we want to try to get our goal sats up within the first 10 minutes. You don't need 100% sats in the first minute, and in fact, there's a kind of a gradual phase-in the first 5 to 10 minutes to allow the sats start at around 65, 70%, the oxygen saturations, and slowly phase its way up to where it needs to be. The temperature in the delivery room should be about 73 to 76 degrees because you don't want a cold baby. The cold stress causes more and more issues as part of its process. So delivery room management, this is for meconium-stained amniotic fluid. This is adjusted over time. Before, if the kid would come out floppy, then you would try to intubate the kid and try to do tracheal suctioning and then kind of determine. With the new requirements in NERP now, all kids you want to assess and establish the airway first. So, if you need a suction and get the kid, get the airway established, get some positive pressure ventilation going, you do that. And so airway, breathing, circulation, initial airway tracheal suction is not indicated. As we determine when we go to intubate, we look at tube size. Typically, the infants are between a 1.5 to 3.5 tube size. The 4.0 ET tube is no longer recommended. Usually your late term are going to be a 3.5 ET tube. Your late 20, like 28 to 34 weeks will probably be a 3.0. Less than 28 weeks will probably be about a 2.5, and usually the small ones, less than 24, you might need a 2.0, but you try to use a 2.5. Typically, my rule of thumb also is that I don't go to the 3.5 ET tube or a 3.0 ET tube until you're about 1 kilo. And so you have to be a minimum of 1 kilo before you go to 3.0. More so predominantly because you don't want to stretch. Even though you can get it in there and the baby probably has a leak, you don't want to stretch that trachea and put them at high risk of having a malacia later on in life. The weight in kilograms, so you kind of estimate the fetal weight and add 6, and this is the tip to lip length. And so when you go to put the ET tube in, if they're a 3 kilo kid, so 3 plus 6, you want to tape it at 9 on the ET tube. If you have still sustained heart rate less than 60, now we have to kind of assess and see why this is ongoing before we start compressions. And so the mnemonic is Mr. SOPA, M-R-S-O-P-A. So the Mr., the M for mask and assess the mask, R for reposition the airway, S for suctioning the airway, O for opening the mouth. Sometimes you put the mask on there and the mouth is still closed. It doesn't help anybody. So you got to open the mouth up and then put the mask on. P, make sure that you got pressure going through. And you can increase that pressure as needed. You might need to give more positive pressure. Now, especially so when we use a NeoPuff device versus the actual bag, it's hard to get a sense of compliance with that with your thumb on the NeoPuff device. And so, the bag, you actually can feel the chest kind of rise against the pressure. The NeoPuff, you can't really do anything. So you might have to really turn over the pressure to get enough chest wall rise. And the last part, A, is airway, to determine if you need an LMA or an endotracheal tube. All right? Cardiac compressions then start, 100 to 150 cycles per minute. You want to compress 1/3 of the AP diameter, usually between the nipples on the sternum, and depress down. Remember the 3-to-1 compression to ventilation ratio, 1 and 2 and 3 and breathe in, 1 and 2 and 3 and breathe in, is the cadence that you'll use for that. Drugs, epinephrine. So epinephrine stimulates the alpha adrenergic receptors, increases your heart rate and arterial constriction, stimulates the cardiac beta adrenergic receptors, enhances contractility, and it's usually only effective after effective ventilation has occurred. The dose for epinephrine, you should kind of get to know, 0.1 to 0.3 mils per kilogram, or it's a 0.01 to 0.03 mgs per kg of the 1 to 10,000 concentration. We don't really use endotracheal administration of epinephrine unless we are desperate. It's best to put it in an IV, if you can put it in a low-lying UV or an IO. If not, and you're desperate, then you put it into the endotracheal. Sodium bicarb. Sodium bicarb is kind of fallen, is used, but it's kind of fallen out of favor. Jody Asher from Vanderbilt kind of looked at this a little bit more closely, and it's really not recommended during initial neonatal resuscitation, and really not recommended for treatment of metabolic acidosis just because of the effects it has on the brain, the neonatal brain. So I would kind of push this aside. Glucose, really no specific recommendations in NRP. You want to check a glucose level. If it's low, if it's less than 40, then you want to intervene. The big thing you want to remember here is first assess the kid. If the kid is not in respiratory distress, meaning that their respiratory rate is less than 70, you can feed the kid while you're waiting to do other things. So if you have a low glucose, look to see, can I feed the kid? If so, feed the kid, put some substrate in. There's new modalities now. Glucose gel is readily available. You can take some glucose gel and rub it on the inside of their mouth, and that usually will also give them a kind of a rub boost. But if they're in respiratory distress, now you have to go through the algorithms like, okay, I gotta get IV access so I can give glucose to the child. Remember, the bolus dose of glucose is D10 at 2 ml per kilogram. Okay, it's not D20 or D25 or D50, not sugar packets. So I've had a pediatrician call me and said they're adding sugar packets to the formula to try to get the glucose up. No, none of that at all. You please just use D10, 2 ml per kilo as a bolus, and then you probably need to start an infusion afterwards. All right, naloxone, again, that's been kind of taken out, is not recommended during initial NRP. Really, you don't use it. Volume, so suspected blood loss, the dose, 10 ml per kilo may be repeated, so you're going to use either normal saline or you use O negative blood. Lactated ringers is really no longer recommended. A lot more infants are getting delayed cord clamping now, and so that holds their volume a lot better. Usually you'll get between 30 and 60 seconds of delayed cord clamping. All right, newborn exam. We're going to go through the different parts of the examination here. So observational and dynamic, and the exam changes a lot early on in life. The baby changes a lot, and that's why they get assessed for the first couple of days of life. And so this is kind of what you want to see your baby. You want to see the head is probably going to be turned to one side. You're going to have molding at the top of the head. A lot of these kids that are vaginally delivered will have kind of that cone-shaped head. This gets better over time. They might see some bruising through there. You might have the blue hands and feet, the acrocyanosis that occurs. You have nice flexion at the knees, kind of flexion at the hips, flexion at the arms. This is a really nice demonstration of how the infant should be. This one looks like it might have even some meconium staining on the nail beds here. So we'll go through the exam real quick. So physical characteristics: lanugo, genitals, soles of feet, breast buds, ears. And at best, by taking all the physical characteristics, so your Ballard scoring that we do, it's broken into two components, kind of the physical exam component and then the neurodevelopmental component. When you do the Ballard scoring, it's at best plus or minus 2 weeks, but you can get a pretty good estimation from that. So the lanugo is that body, that's that hair that's over the entire body. So remember, the lanugo is covering the entire body less than 32 weeks. By about 32 to 37 weeks, the face starts getting more cleared from that. And then by the late term, 38 to 40 weeks, you start seeing less and less on the shoulders. And usually post-term, at 42 weeks on, is when that lanugo should be gone. Genitalia, in males, you want to see if their testicles are descended. They remember they kind of reside in the lower pelvis, and they kind of come down through the tracts, the inguinal canals, and then kind of descend into the scrotal sac. If you look at their scrotum, at about 28, 35 weeks, the testes are usually within the canal, and there are very few rugae that you may see on the scrotum. At 36 to 39 weeks, it'll be seen more in the upper scrotum. At 40 to 41 weeks, the rugaes are fully completed, and you'll see it in the lower scrotum. And at 42 weeks, they've got these pendulous, looking scrotum that'll exist there. In females, it's looking at the clitoris, the labia minora, and the labia majora. So the clitoris is prominent, and so in the premature infant, particularly less than 35 weeks, you'll see a very prominent clitoris, and the labia majora can't close over the labia minora. As they get closer to becoming term, the labia majora will start to cover the clitoris, and at term, at 40 weeks, the labia majora covers the labia minora and is fully in blocking in view, so you can tell that the child is at more of a term gestation at that point. When you look at the foot, in a premature infant, they usually don't have any creases on their foot. Especially at 24 to 31 weeks, you'll not find any creases on their sole. You may start to see primary creases about 32, 33 weeks, and those will start to increase. About 36 weeks, so almost the last month in the pregnancy, you'll start to see more creases in about 2/3 of the feet, and then full heel, toe to heel at about 38 weeks. Breast buds, the areola is barely visible, and there's no bud that's present at less than 32 weeks. It's raised at about 34 to 35 weeks, 1 to 2 millimeters at about 36 to 37 weeks, 3 to 5 at about 38, 5 to 6 at 39, and 7 to 10 at 40, greater than 40 weeks. Ears, the appearance, usually they're flattened against the head at about 24 to 33 weeks. And the thing about the ears is you want to look at the elastic recoil. So when you fold the ear down, does it pop? If you take your ear and just kind of fold it over, it usually pops back into place. In premature infants, particularly as when they're really premature, you'll hold it and it just stays flattened like that, like you folded a piece of paper or so. Superior incurve about 34 to 35, upper 2/3, 36 to 38, and you get a well-defined earlobe by about 39. So when you start to put these pieces together, you can start to get an idea of what the gestation of the infant may be at. And here's that cartilage I was talking about. So soft and stays folded about 24 to 31 weeks. If it slowly, like a rose petal opening back up again, it's about 32 to 35 weeks. If it's thin but it has a little bit of pap, it's 36 to 39. But if it really pops back, you're getting up to term. All right, so during a newborn exam, you notice that the infant is entirely covered by lanugo. He has no foot sole creases or breast buds and has flat, soft ears with no recoil. Five seconds. Very good. 30 weeks. Oh, I'm teaching you something. Excellent. All right. So weight, head circumference, growth charts. We talked a little bit about the AGA, SGA, and LGA, and disproportionate growth. So we want to see the infant when they're in their kind of in an active state. See how alert they are. Do they cry? And this varies. All babies don't just sleep the entire time, nor are they awake the entire time. The cry can tell us a lot about an infant. If it's a hoarse cry, if they kind of have a very weak cry, they might have cord paralysis that may have occurred. That hoarse cry we see in hypothyroidism. If there was trauma, if there's a stretch, and like if a forceps delivery and they cause a facial nerve palsy, or if there was trauma to one of the cranial nerves, that may affect their sound. The high-pitched cat-like cry we see in kids that have chromosome deficiencies, like Cru de Chat. Okay, so those are the types of the higher pitched cries. The shrills that are really like kind of the oh my god, that's there's something wrong with that kid. Those are more like neuro cries. So if there's a neuro anomaly or neonatal abstinence, we'll hear a very, very, very high pitched cry. Temperature, we try to do in infants, we try to get a rectal temperature initially. As they, so much so the way that things are, they do accelerated temps on these kids. We want to make sure that the fluctuation is not an environmental cause, but that they're real. Infants, when they're hypothermic, put themselves at risk of a lot of different issues: sepsis, hypoglycemia, hypoxia, hypothyroidism. If they're too warm, could they be infected? Could there be a hemorrhage that's going on? Is there neonatal withdrawal that's ongoing? So we look at the skin, and the skin will give us some information if there's meconium staining that's there. Sometimes the meconium staining you'll see in the nail beds of the infant. If they are very pale in appearance, is it from anemia? Is it from sepsis? Is it from hypothermia? If they're bluish, we try to determine if it's centrally, so it's like around the lips or so, or do we just see kind of blue, the acrocyanosis in the hands and feet? And this is the vasodilatation that occurs in the peripheral extremities. It's not uncommon to see it in the hands and feet, but if you have blueness around the mouth and the lips, that's a lot more concerning sign and symptom. If the child's ruddy, as you can see the little baby on the left, more question of polycythemia. They might have a high hematocrit count. You want to think the kids that are ruddy that are probably at either infant or diabetic moms are going to be at high risk for that, or delayed cord clamping puts them at high risk for that. Harlequin babies, these are the babies when you look at them straight on, if you took a line and drew it down the middle, half of them is ruddy and half of them is anemic. It's really kind of odd. It doesn't follow any dermatome pattern at all, but if you just look straight down the middle, like one half of their body is like really plethoric and the other one is not. And those are the kids that are harlequin. Those kids are fine, actually. There are vasomotor instabilities that exist there, and they're short-lived, and they usually don't come back. So we don't worry too much about those. And jaundice. This is that yellowish-orange color that you see within the skin. We're going to talk a lot about jaundice in a little bit. Remember, the caveat for jaundice is that you cannot eyeball a kid and say, you can say the kid's jaundiced, but you can't say, well, that's a 12, or that kid has an 8, or that kid was if it's up to here, it's about a 7. They used to do that in the past, and that's why kids have kernicterus. So we don't do that anymore, all right? We have machines that do that for us. You cannot eyeball a kid to determine the level of jaundice they are. All right, skin. So blisters. Blisters can occur. Sometimes you can get sucking blisters. So babies that are in utero might be sucking on their hand, and they can get like a nice blister within their hand because that's where they've been sucking on. Post-dates, you'll see more blisters. We always worry about infection when we see blisters on the hand. Petechiae, it depends on if it's a generalized petechiae or if it's in just a single area. Remember the petechiae, we don't want to mix that with blueberry muffin rashes. The extramedullary hematopoiesis. When we talk about torch infections here later today, I'll give you some ways to remember some of those extra rashes. Sub-Q fat necrosis. These are the pockets that usually occur. They're firm, mobile, erythematous nodules. You usually see them on the buttocks. You see them on the cheek, arms, thighs. Just think hypercalcemia when you see sub-Q fat necrosis. Okay. Higher levels of calcium in the blood, and so usually you'll see kind of a patch area right on the cheek is what a favorite board question that they ask with a picture. They'll show a kid with like kind of a round nodule that looks hardened almost, on the cheek, and what is this kid at risk for? Hypercalcemia. Cutis aplasia congenita. This is the patch that is on the scalp, as you see here in the bottom left, and that is kind of a empty patch that is there. It's kind of almost like there's no bone that's there. It's like just skin, and these are commonly seen in trisomy 13, but you don't have to have trisomy 13 to have cutis aplasia congenita. You treat these like a burn, so you'll put some Silvadene. If they're really big, you might need to put some Silvadene on that and protect that for the infant. Ecchymosis and rashes. So two of the other types of rashes that you should become familiar with. One is erythema toxicum neonatorum. And so it sounds really threatening, erythema toxicum, neonatorum. So this is usually seen in the Caucasian kids. You usually see them at day 2 to 5 of life. They're like kind of the lesions that you'll see over the arms and the chest and the face. Remember that if you were to scalp one of these lesions and culture it, erythema toxicum, you're going to see eosinophils. So E for E, erythema toxicum, you're going to see eosinophils within that. The other one is neonatal pustular melanosis. So neonatal pustular melanosis we see commonly in African American kids. They almost look like little blue spots on the kid. If you were to lance that and culture and do a histo on that, you'll see neutrophils. For neonatal pustular melanosis, N for N, E for E. So erythema toxicum neonatorum, you'll see eosinophils, and neonatal pustular melanosis, you'll see neutrophils, okay? All right, so the newborn exam, the head. So the shape of the head is really important. It kind of gives us kind of an idea of what's going on. In premature infants, they have what a lot of times you'll hear the terminology toaster head. My youngest kid was a 33-week premature infant, so I can say that. He had a toaster head, and it's that kind of narrowed diameter. We have two fontanelles. We have the anterior and the posterior fontanelle. The anterior fontanelle can give us a lot of information. Usually in African American kids, they have very large anterior fontanelles. In Asian kids, in Caucasian kids, the anterior fontanelles may be much, much smaller. If you have a very, very large anterior fontanelle, I'm talking about like goes from here to the mid part of the head, you worry about hypothyroidism in those kids. And so then we also look at the plagiocephaly and craniosynostosis, and so or dolichocephaly. And so depending on if there's positional, a lot of times kids will want to preferentially lie to one side. If they have torticollis and their neck muscles shortened, they may lay on one side, and that molding that occurs early on will cause the head to be misshapen. In old country back home, a lot of times they take a donut roll and they'll have the kid like lay kind of perfectly in that donut roll to make their head look all perfect, or they put a hard slate underneath where they lay to try to shape the head. Now we have helmets, and so you can go to a neurosurgery doc if you really are worried about the shape of your head, and you can get a proper fitting helmet to kind of reposition. But you always want to take a look at the sutures, make sure the sutures that are there, everything should be able to be movable. Remember, the brain grows a tremendous amount in that first year of life, and it has to have the ability to kind of shift and like tectonic plates almost. But those sutures, sometimes if they are fused shut, and you can feel those ridges fused, they can have craniosynostosis, and that could be a problem down the line. All right. Caput and cephalohematomas. So there are two types of bleeds that we worry about, or fluid fields that are in the head. The caput succedaneum crosses suture lines and is usually above the periosteum. And so you can see up here, here's your periosteal level right here. And so there's the caput succedaneum, and through here, here's your periosteum right here. So caput, and then cephalos, it's a hematoma, so it's blood. It doesn't cross suture lines. It sits beneath the periosteum. The best way to remember it is caput succedaneum is 2 words, so it goes on both sides of the suture line. Cephalohematoma is 1 word, so it stays within the suture line. It doesn't cross. So caput goes both sides, 2 words. Cephalo, 1 word, stays on one side. Okay? Subgaleal hemorrhage. Beneath the scalp, aponeurotica, and it usually kind of pulls the ears forward, and that's one of the ways you can kind of determine. Usually if you worry about a subgaleal, we have protocols that are set up in hospitals. You do serial hematocrit checks, probably serial head ultrasounds. You do serial levels of checks and determine if the kid's losing their blood volume very quickly, they may need a transfusion, they may need intervention sooner than later. And so, caput cephalotoma and subgaleal hemorrhages. We also look to see if there are fractures. Back when the forceps were more uncommon, you may see these linear fractures that occur within the scalp. Usually the linear ones are benign. They have these ping pong type fractures, typically in the parieto-temporal region. If you ever see a ping pong ball and when you push it in, this is what that would look like, and you can kind of see it here on that. Depending on how significant this is, neurosurgery may need to intervene and kind of pop it back out because it might impede on normal brain growth and development. If it's a basal occipital fracture, there's increased risk of other injuries. Intracranial hemorrhage, and so these are more common than appreciated, can be seen as high as 25%. We always worry about intracranial hemorrhage in infants that have low platelet counts, especially if they have higher risk of neonatal alloimmune thrombocytopenia. The subdural and subarachnoid are most common, majority are asymptomatic. And you can see where those will locate. Here's subdural hemorrhages out here, subarachnoids through, parenchymal bleeding within the brain space, those are bad. The intraventricular, so here's your lateral ventricles, and through here. The intraventricular hemorrhage is more common to be seen in the premature infants, so less than 30 weeks gestation. And then epidural hemorrhages, these can be arterial or venous, and you need to watch these. And these are all kind of diagnosed by a CT MRI. Just a quick thing about intraventricular hemorrhages. Remember, there are 4 grades. So grade 1s, remember if you look at the lateral ventricle, they look like in Chicago, the Chicago Bears C sign. Their logo is like a C that's sideways. So if you're looking at it from the side view, and the Chicago Bears C, this is your lateral ventricle. This pocket that sits right in here is called the germinal matrix. That germinal matrix is where all those blood vessels kind of come and coalesce. And in the really premature infant, those blood vessels are very thin, and that blood-brain barrier is very immature, that they have a tendency to bleed. So bleeding that occurs in that germinal matrix is called grade 1. If that bleeding leaks into the ventricular space, we call that grade 2. If it leaks into the ventricular space and causes that space to swell, the ventricle to swell, it's a grade 3. And if there's bleeding that kind of occurs throughout the parenchyma, it's grade 4. The grade 3s and 4s, remember, have higher risk of developmental delays, cerebral palsy, etc. The grade 1s and 2s usually resolve and do well, okay? All right, eyes. So term, you usually have a conjugate gaze with visual fixation. If you can take a look at the eyes, particularly the eye over here, if you do a Hirschberg's test, the point that the light shines on the eye should be symmetrical on both sides. And so if you have a child whose light doesn't line up, they may have a lag within their eye. You want to take a look at their lid. Horner syndrome, which is a lower brachial plexus injury. You're going to assess for ptosis, meiosis, and anhidrosis. Microphthalmia, proptosis, if the eyes are really bulging forward and almost displaced, you want to think of a mass that might be behind there pushing it forward. If there are subconjunctival hemorrhages, those aren't necessarily dangerous, but they may be secondary from a birth injury as they were coming out. And then conjunctivitis, GC chlamydia, typically beyond the first 48 hours of life. When we do an ophthalmoscope assessment, we always want to look for red reflex. The red reflex exam in the baby is probably one of the 3 most important features of the newborn exam. If I had to pick 3 things that have to be done, you do the red reflex, you do a femoral pulse exam with your auscultation, and your hip exam. Or probably there's only 3 things you can do on a baby, those are the 3 things you want to do. The hip, red reflex, and then femoral pulse / auscultation. So red reflex is really vital for the detection of cataracts, glaucomas, and colobomas. If you see colobomas, the coloboma, as you can see here, is like, you can see where it is kind of almost dripping down, it feels like. It's they call the keyhole, and it looks like a keyhole where you just put a key inside. Those are colobomas. You want to think charge syndrome. So here's a red reflex that is normal, and sometimes you don't see it. And these are really hard to kind of catch, particularly in African American kids. You may have a difficult time seeing the red reflex, or in certain types of Asian kids, it might be very, very pale, and it looks almost white to you. And so you want to think, when you start to not see a red reflex, to question yourself, does this kid have a high risk of congenital cataract? And the reason why is that congenital cataract is one of the congenital infections that is seen in one of the congenital infections. So cataracts are seen typically in congenital rubella. Usually they'll have other symptomatology that's there, and we'll go over that in a little bit. But cataracts are one of those kind of sign points, just like, hey, there's something else going. So cataract's one that you want to look for, retinoblastoma, or if the eye is not fully formed and developed, they may not have anything. So you really want to make sure that the red reflex, if it's not present, probably warrants a further assessment. If you do not get the eye exam early on, make sure you get it done before the kid goes home. Sometimes they're really hard and they're crying and they are really tight and impossible to open up. And so you want to come back at a different time and make a mental note and see that. Okay. Other visual and hearing, think torch infections, congenital cataracts, as we mentioned, for rubella, CNS calcifications, toxoplasmosis and CMV, grouped vesicles like herpes, limb hypoplasia, microphthalmia, I think varicella, and bony changes or hemorrhagic rhinitis, syphilis. And I'll go, there's a slide I have a little bit later that's all about torch, and we'll go over all of the torch. What you see here, I want you to kind of impregnate this image in your head. This is a kid who has syphilis. This is that mucopurulent rhinorrhea. This is called snuffles, all right? And so the snuffles that you see here is just that, the kid that, I don't know, remember the kid back in the neighborhood that was like, there was always one kid on the block that has the worst runny nose, and it was to kind of drain down into their mouth, and you're like, oh my God, Imagine that like 20-fold. And just the worst, and the worst part about this is that exudate that's coming out is full of spirochetes. So it's extremely, extremely infectious. So if you have cuts on your hands or fingers, you got syphilis now, all right? So it's the way they say, it's the gift that keeps on giving, right? So the other feature, these kind of cracks on the corner of the mouth, these are called rogades, all right? And so I just want you to just remember this image when we talk about these things in the slide coming up. Newborn exam for ears, the preauricular pits and tags. We used to make a huge ordeal, like, oh my God, he's got a tag, he's got an ear tag. We got to get a renal ultrasound, and we got to do all this other stuff. Now we do nothing, So if there's just an isolated finding, and in fact, preauricular tags kind of runs in families. You might see one person have it, and then you look at the dad, and he's got it, and grandpa's probably got it as well. So the preauricular tags are not too much. The pits might be a little bit more substance to that, but if the pits have to usually have another finding. So it's a pit plus, maybe renal dilatation in utero seen, or a pit plus some cardiac issue, or then you might want to do more of an exam for that. Otherwise, you don't worry. We look at positioning, low set ears, rotated ears, or microtia. So when you take the eye and kind of make a perpendicular line, it should kind of intersect the top third of the ear. Usually if it's not, and they're lower set and they're posteriorly rotated, those kids are probably at higher risk of having some congenital chromosomal anomaly. And it's kind of difficult to see. Or if it's really posteriorly rotated, you worry about, is there a mass effect causing that ear to be so rotated in there? So think syndromes, urogenital, and other anomalies. One other note about the eye again, remember the newborn eyes are fused shut till about 25, 26 weeks gestation. And so usually when they're born, that's the other thing I always look for in my med students' examinations. When we get a 24-weeker or a 22-weeker, they'll say, yeah, red reflex seen bilaterally. And they're like, the kid's eyes are like completely fused, And so usually they open those up with about 24-ish weeks, 25 weeks. The eyes, the fusion improves. All right, nose, stuffiness, trauma, syphilis, as you can tell from the previous image of the mucopurulent rhinoritis, drug withdrawal. We worry about choanal atresia on these kids. Choanal atresia, remember, babies are obligate nose breathers, all right? They don't know how to breathe from their mouth. So if they're blocked up here, they're going to get in trouble very quickly, okay? And so the choanal atresia, usually you want to pass a feeding tube into both nares to see if it goes through, and if there's obstruction or there's a narrowing, That might be a sign or a cue that there's choanal atresia. Other things you might worry about is that there's cyanosis or distress that improves with crying. Again, think charge syndrome. It could be bony or membranous. Mouth exam, you want to look for cleft palate or look at the uvula and see if it's a bifid uvula. But you want to take a look at the hard palate, make sure that it's all come together. And I would run always your finger to the posterior portion and look at the soft palate, because sometimes you can have a normal hard palate, but you can have a clefting of the soft palate. And pretty much what happens is that the mouth gets crowded and the tongue gets pushed up. And so when the cells kind of come together to fuse, if the tongue is up in that area, it's not going to come, and that's where the clefting then occurs. Epstein pearls, so there are three type of cysts, sebaceous cysts that occur. Three type of epidermal cysts. So sebaceous cysts, Epstein's pearls, Bohn's nodules, and milia are the three type of cysts that can occur. And so the Epstein's pearls is like a little pearl. If you open the back of the mouth and you'll see a little white pearl right on the hard palate of a baby, those are Epstein's pearls, completely benign. On the lower inferior alveolar gum, you'll see the Bohn's nodules, B-O-H-N, and then you might see milia, these epidermal inclusion cysts that are on the nose. Those are very normal. These are all the same type of category. Ranulas are benign masses. These are benign mucoceles. Usually they're underneath the mouth, in kind of that floor of the mouth area is when you're going to see a ranula. And then you want to palpate for submucosal clefts as well. So the tongue, ankyloglossia, so you might see some tongue tying that cause that serpent-shaped tongue. So the lower frenulum will kind of come to the tip of the tongue and kind of cause the tongue to become bifid almost, depending on the severity of it. There's a lot of discussion and debate as to what you do with these. Some people will debate that you need to clip them all. Pediatricians do them. Other people say, no, you don't, just leave them alone. My rule of thumb is that if it doesn't cause any difficulty in feeding for the child, you let it be. And usually it doesn't cause any issues with speech. And the only thing they can't really do is roll their R's in the future. But if it's causing a lot of speech difficulty and you're feeling a problem there, then you can go ahead and clip. Protruding with small mouth and cleft, usually if you have a really small jaw, we worry about Pierre-Robin sequence. If you have a really protruding tongue, a large tongue, think about Down syndrome, think about hypothyroidism, and think about Beckwith-Wiedemann, particularly if you have hypotonia plus large tongue in the newborn, because they may or may not have omphalocele, but think about Beckwith-Wiedemann syndrome. And then teeth. Usually you might see some natal teeth that are there. Usually they're in the inferior gum line, and usually they're in pairs. If they're embedded in place, you need to kind of follow these because they can become unbedded very quickly, and the biggest risk you want is not for the child to aspirate that too, when it gets loose. If they're loose, you need to have a dentist come in to remove those teeth. The only thing I warn the moms that are breastfeeding is that it might be painful as they kind of clamp down if they have teeth, but usually within the first week, those teeth can become very loose very quickly. If you have a single central incisor on top, those kids are probably a growth hormone deficiency, is the little pearl there. So one single central upper incisor is growth hormone deficiency. The neck, so we look at masses in the neck, goiter, hemangioma, cystic hygromas, thyroglossal duct cysts, ventral midline. This is usually kind of, you'll see it kind of in the center, and as you swallow, it moves up and down. Torticollis, this is head that is turned towards the side of injury, so the kid's neck kind of preferentially wants to be on one side. A lot of physical therapy is necessary to kind of re-stretch that neck back out because the kid's like kind of used to, and when mom goes to feed the baby, they kind of feed to the preferential side because it's easier. They don't want to, and so you try to have them switch over to help them out. So branchial clefts and branchial fistulas. Usually, here I kind of put a picture in here. Here's your external auditory canal. Here's your sternocleidomastoid muscle. And as you go down from the external auditory canal to the sternum, you can hit your first, second, and third branchial fistulas. So the first branchial fistula is usually kind of right underneath the ear, and you can see that because it's so close to the ear, it's probably got some auditory issues that are related to it. So Drainage, sinus, external auditory canal issues are probably associated with the first branchial fistula. The second, now you're going a little bit further down. Usually what you see is a pinpoint lesion on the side of the neck. Usually there's a lot of drainage that is coming from that. That fistula, the caveat that you want to know from the second branchial fistula is that little fistula that exists, the lining of that, the epithelial lining, is at increased risk for squamous cell carcinomas. Okay? So they have a higher risk of squamous cell carcinomas. And the third one is way down at the base, and you'll actually feel a lump toward the bottom there. All right? The chest, we always want to look for clavicular fractures. You may feel some kind of crepitus within that clavicular area. You don't put a figure of 8. If you do feel a fracture, this is one thing on x-rays that they commonly like to throw an x-ray up there and say, you're thinking about a respiratory problem, and they'll have a blaring clavicular fracture sitting right there. And so I try to advise my students to always take a look at everything other than what you want to look at the x-ray for. So if you're getting the x-ray for pneumonia, look at everything else first and then focus on the pneumonia. That way you'll train your brain to look at the whole x-ray. So look at the soft tissue, look at the bones, look at any fractures, and then go look to see if there's pneumonia or anything there. The supernumerary or wide space nipples, they did so Dr. Chen from LSU looked at about, 500-600 term infants, and she measured the internipple distance, the INI, or she has an internipple index, and measured that nipple distance on all these babies, and that's how she determined what's normal and what's not normal. And so it really kind of assesses optimum size if the nipples are too far apart or if they're narrow. Breast hypertrophy. So you get a dad that comes in with his son, newborn son, and he's excreting like this white substance from his nipples, and he's like, "What the heck is going on?" And it's what they call witch's milk. You try to advise him not to squeeze that, because if you squeeze it, it stimulates prolactin, and that stimulation of prolactin will stimulate oxytocin production, and it will cause a mastitis in this issue. So you just let it be, and it usually, as the hormones kind of balance out, it goes away completely. All right, lungs. So the respiratory effort and pattern of the lungs are what you want to take a look at. You want to make sure the baby's breathing. Babies have a tendency to do what's called periodic breathing, so they take these short, shallow breaths, and then pause, and then pause. When these pauses last less than 20 seconds, we don't worry about them. We just call it periodic breathing. When these pauses last beyond 20 seconds, it's apnea, and that's a problem. And so kids that are less than 35 weeks gestation are at higher risk of apnea because the receptors from the brain to the breathing centers are still immature and developing, and so these pauses can be much more profound. And what happens in apnea is that they don't breathe, and then over a period of time, or in periodic breathing that are profound, lots of periodic breathing occurs, and then the heart rate starts to drop. And in apnea, not only the heart rate starts to drop, but the blood pressure starts to take a tumble as well. All right? So primary or secondary apnea. And so this is when we have to intervene. In infants, we give caffeine. It works just like it does in adults. Nice pickup and stimulant in the morning. We give a little bit of caffeine to the infants once a day, and usually it does the trick. It's much better than the old drugs that they used to use that cause a lot of cardiac issues. We worry about tachypnea, greater than 70 breaths per minute. We always worry about the baby's breathing, and if they're breathing more than 70 times a minute, they shouldn't be orally feeding because it puts them at high risk of having aspiration. So tachypnea can be pulmonary induced, cardiac induced, or metabolic. And so the pulmonary is if there's extra fluid in the lungs, if there's surfactant deficiency, and they're in distress. Cardiac, a lot of times if their heart is not pumping adequately and the blood flow is not getting to the lungs adequately, they're in failure, and metabolic is more similar to the cardiac. If they're retracting, you can have subcostal retractions. You can have intercostal retractions bilaterally, and you can have the suprasternal retractions. And so we want to see if the kid's grunting. Remember, when they are trying to increase that intrathoracic pressure, they might go when they're trying to breathe, and they do the nasal flaring and allow that air to come in to help them with some of the distress that they're in. We always assess for breath sounds, if they're equal, unequal, stridor, wheezes, rails. All right, heart exam. So the PMI displacement Usually normal in the 4th to 5th interspace on the left. You worry about tension pneumothorax or dextrocardia. Look at the rate of the heart and see if they're low heart rate, so usually less than 100. I worry only if it causes them to have desaturations. So some infants may have a low resting heart rate that sits between 90 and 100, but they don't desaturate and they don't have any other problems at all. Usually you can reset the alarms and not worry too much about them. But kids that have heart rates that are lower than 70, then you have to be a little bit more concerned. And we always worry about heart block. So maternal SLE is one of the things that we know that causes heart block in the newborn infant. The SSB, or anti-Ro, anti-La antibodies. And so those are the ones that we worry about third-degree heart block. Now, I'm going to give you a little poem song to remember for heart blocks, and you can kind of tuck it away for your cardiology lecture later. Like I told you, I have a whole bunch of mnemonics. So remember, when we look at heart blocks, we look at 3 components. We always look at the EKG. You have to have a P wave right here. And this is where the atrial contraction and repolarization occurs. You have a QRS complex, so QRS, and that's usually your ventricular contraction, and then you have a T wave, and so that's your ventricular repolarization. So P, QRS, T, P, QRS, T. And whenever I look at any EKG, P, QRS, big T, P, QRS, big T, right? You always want to make sure that those fundamental components should always be there. If you can find the PQRST, you're already like 70% on the way home to figure out EKGs. If it's not there, then you start to figure out what's missing and why is it not there, and you can kind of backtrack and figure out what's going on. The other 2 caveats is we always look at the QRS complex and make sure that it's not too wide, right? It has to be within like a couple of boxes, and that distance between the P to the Q is not too far. Okay, that should also be between a couple of boxes. If it gets too far, that means it's like getting stuck in the contraction. That's where the blocks are occurring. So here's the thing. So you have PQRST, now you have a little bit of preference. So if the R is far from P, so if this R is far from the P, then you have first degree. Okay? If the R is far from P, then you have first degree. Longer, 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 drop. So if that P wave, it's like small, and then it gets longer and longer and longer, and then you drop, then you have Wenckebach. Okay? If some P's just don't get through, now you're in Mobitz 2. So the P wave doesn't make its way through, you're in Mobitz 2. And if the P's and Q's can't agree, then you have third degree. All right? So one more time. If the R is far from P, then you're in first degree. Longer, 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 drop. Now you have Wenckebach. If some P's don't get through, well, now you have Mobitz 2. If P's and Q's don't agree, now you're in third degree. And hopefully that'll help you remember all the different types of heart blocks. Okay? Everybody good? All right. Tachycardia, greater than 180 beats per minute. Usually when you get up that high, we worry about supraventricular tachycardia, and we always worry about that because sustained supraventricular tachycardia, if they're not hemodynamically stable, then they can go into other more serious complications. And so the other thing about supraventricular tachycardia that I want you to remember is that usually you have a heart rate over 200, so there's lines of defense for that. So one of the lines of defense is to do a vagal maneuver. We're not going to rub the eyeballs. We're not going to stimulate the carotids, okay? So, and you can't tell the baby to strain down and have a poop at that point, because that's not going to help either. And so what you want to do is take an ice bag, fill it up with water and ice, and you're going to smother that face. And it feels barbaric almost. You're like, oh my God, what am I doing to this kid? But you need to kind of cause that break to occur to allow them to get out of that SVT. If that doesn't work and you're still having difficulties, adenosine is a drug of choice. Remember the caveat with adenosine is 2 parts. One, it has a very, very short half-life, very, very short. So whatever IV access you have to have the adenosine ready, you have to have your flush ready. So one goes right after the other to be able to get that drug to the heart in a timely manner. And what happens when you give adenosine? You get a heart rate, it's like dee, 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 beep, and now your heart rate is like gone to zero as well. You're like, oh my God, and then beep, 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 and you've converted them over. So there is going to be a break when the heart rate stops probably, and it'll give you palpitations, but usually you have your friendly cardiologist on standby waiting with you. So, all right. Other parts of tachycardia: fever, hypovolemia, dysrhythmia, hyperthyroid, and drug withdrawal. So the murmurs are heard early in life in the initial exam. Most common are valvular stenosis, also constricting PDAs and tricuspid regurg. So the things to think about murmurs is if you look at the heart, so you have the right upper sternal border, left upper sternal border, left lower sternal border, and then the apex, okay? So if you start from this side and kind of work your way across, and alphabetically, the first letter of the alphabet is A. Upper right sternal border, you're going to hear aortic type murmurs. So aortic stenosis is where you're going to hear these type of murmurs. Then the next is the pulmonic. If aortic's up here, the pulmonic then is going to be on the left upper sternal. When you get down to the left lower sternal, these are the tricuspid murmurs. And then as you go to the apex, these are the mitral murmurs that you're going to hear. So the reason I'm saying this is that when you start to read these vignettes, you're not going to kind of make it so blatant. So they may give you a location where you're hearing the murmur, and that might help kind of lead some of the answer choices. And so the idea is the boards are not like clinically perfect. The boards are designed in a certain way to make you think in a certain way. And so in order to transform your brains to get to that pathway, try to use their secrets that they're giving you to determine what you're looking for. All right, so cyanosis and murmurs, and we'll talk about the cyanotic murmurs in just a little bit. We'll keep going on. So repeat exam warranted. Remember that the ductus arterius murmur, the ductus is wide open, and after the first day of life, you may start to see the narrowing of that ductus and might start to hear a murmur of the ductus. And then after 2 or 3 days, when the ductus finally closes, you may not hear the murmur. And as it's closing, it may get louder. Remember, when you take a pose and water's flowing it, the more you pinch it, the faster the water comes out. That's that turbulence you're going to feel until it fully closes. So the murmur may technically get louder before it gets softer. All right? If it's heard at greater than 24 hours, you worry about a VSD. The VSD is that loud kind of like a hum in the middle of the chest. We always worry about in Down syndrome kids. Remember, in Down trisomy 21, they have a high risk of having AV canal and VSDs. You do not need a murmur in Down syndrome kid to get an echocardiogram. 50% of these kids they'll have balance of their lesion, and they may not have a murmur at all. But if they are trisomy 21, you're going to get a echocardiogram regardless. Okay? Always check the femoral pulses. Remember I said that's probably one of the most important parts of the examination as you're moving forward. All right, newborn exam, abdomen. Liver, spleen, palpation. The abdomen is, these are the things that you want to take a look at. The masses that are most there. The most common mass of the abdomen is probably renal in nature. So hydronephrosis is one of the biggest things that we worry about. Delayed cord separation. Usually, if you have a delayed cord separation, it's probably from a leukocyte adhesion deficiency. Phagocytic defect. These kids are probably higher risk of having infections, and they have a poor white blood cell response. So typically on the boards, when they talk about a delayed cord separation, kids 2 to 3 weeks, now in the 3rd to 4th week, or 3rd week of life, and the cord hasn't fallen off yet, and you're worried. And so one of the things you're going to probably assess for is leukocyte adhesion deficiency in these type of kids. Diastasis recti, so in this kid, you can see here, it's just kind of incomplete closure of the abdominal wall, the abdomen. You can kind of see this kind of bulge. That's usually central midline that has occurred there. If you see this on the infant, these are very normal, and that's just diastasis recti. It's like just weakening of the abdominal wall musculature. Prune belly syndrome, as you see down in this kid here. This is the absent anterior abdominal wall musculature. Usually these kids will have urinary tract anomalies and cryptorchidism. We always worry about the chest because, remember, the renal process helps with the amniotic fluid, and if there's not enough amniotic fluid, these kids usually are not swallowing that amniotic fluid to help with their lung growth and development, and their chests don't get to grow nearly as well. All right, and so their chests usually are what they call bell-shaped in appearance, and these kids will have some higher risk of having pulmonary issues. The kids that just have just prune belly alone in their belly, these kids will have feeding intolerance. Remember that their intestines are just kind of been not contained and kind of slow moving there. Food usually has a difficult time getting through. Gastroschisis and omphalocele. So the way to remember, if you look at both words, omphalocele is an O, it's complete, circle, and so it has a bag around it, all right? Gastroschisis, the G is like broken circle. It's like, if you look at a G, it's like there's broken there, and so it's not got a bag around it, okay? Omphalocele, O, have other anomalies that are associated with, so it's a defect through the umbilicus, covered by membrane. There are other issues that on go. So you usually do a midline workup. Beckwith-Wiedemann is one of those things you have to worry about. But omphaloceles usually have chromosomal issues. They can have cardiac issues associated. So you got to do other assessments when you worry about omphalocele. Gastroschisis, gastro has gut issues that go with it. So usually they have feeding intolerance. They'll have higher risk of strictures. And so when they have just an isolated gastroschisis, you worry about more of the gut type issues. It's a defect lateral to the umbilicus, not covered by a membrane. And so that's how you can differentiate the two, okay? The thing with gastroschisis that you also want to make sure is that that intestine has been kind of swimming in the amniotic fluid throughout the entire of the pregnancy, and so it's going to be very, very slow in returning. So usually a lot of times what they do with the gastroschisis is that they'll do a primary closure. So at the time of delivery, they go to the delivery room, they deliver, and they look at the integrity of the bowel, and then within the hour, they're to the OR, and they try to get it all packed back in. And if there's enough room in the belly, as that valve gets pushed back in the belly, it's going to put a lot more pressure on the diaphragm, makes it a little bit more difficult to breathe. But if the pressure stays within a tight range, they can get all that bowel back in the belly. But it takes about 10 to 14 days before that bowel function starts to return, where they're able to tolerate enteral feeds. Genitalia, females, you want to make sure they have a separate urethra and vaginal opening. Vaginal discharge can be fairly common early on, particularly as the mom's estrogen really starts to transition over. Imperforate hymen, we always worry about that kind of bulging bag that might be below, and it may be described as an abdominal mass. Males, look at the penis, 2.5 centimeters stretched. If it's less than that, they might require an endocrine workup. If they have a hypospadias, we try not to do hypo or epispadias. We try not to do a circumcision on them. And we always try to assess the testicles and make sure where they're at. If they're high riding, if there's a question mark about the testicles, if you can't feel them in the canal and you don't know where they're at, you should get a pelvic ultrasound to take a look. Because if they are truly in the pelvis, they need to be brought down. Those kids that are not brought down in a timely manner are at higher risk of having cancer for that. Ambiguous, we always are, if there's a question mark about the genitalia of an infant, then we have a discussion. We don't really determine or say, we don't say it. Your baby doesn't, we're still having question marks about it, and we need to kind of do further assessments and tests to see what is going on. Try to use more not fully developed. We don't say that they're weird or there's something else that's there. All right? Anus. Imperforate anuses, if there, it is usually kind of decompress the bowel and they have to go to surgery. Fistula, perineum, bladder, urethra. The anus may appear normal, but still may be imperforate. So you always want to take a proper assessment, but you really want to assess for a stool to come out. That first stool that's going to be coming out is meconium. It's usually passed within the first 12 hours, 99% within the first 48 hours. If you don't pass meconium in the first 48 hours, then you need to assess the kid to see if they have Hirschsprung's, meconium plug, meconium ileus, hypothyroid. If meconium plug or ileus comes on your differential and there is a concern that is there, then that child must be assessed for cystic fibrosis, okay? All right, the back, sacral dimple rule. I always look at to see if there's a dimple. The dimples usually are midline in the lumbar sacral region, maybe even close to where the gluteal fold is, right at the top part of the gluteal fold. If you spread that area apart, you want to make sure you always see the base. If you can see the base of the skin, you're usually home free. If you cannot visualize the base, then you really need to do a sacral ultrasound to assess if there is a pull from the conus medullaris and a risk of having a myelomeningocele. If there are tufts of hair that are coming there, again, if you can see the base very clearly and there's a small tuft of hair, I don't worry too significantly about it. But if there's a significant amount of there, also requires a ultrasound or an MRI of the spine to take a look. All right, arms. We look at digits, supernumerary digits, and we look at the if they're axial or post-axial. Remember, the post-axial are usually autosomal dominant. Usually they run in families. African-American kids seem to have it. They'll have an extra digit off the, if you look at the axis through here, it's kind of off the axis. And you're like, oh, your kid's got a 6th digit. And dad will show you, he's like, yeah, I had one too when I was a kid. And grandpa says, yeah, I had one too when I was a kid. So autosomal dominant. The axial ones are usually autosomal recessive. And so those are usually got genetic anomalies that are associated with that on those supernumerary digits. All right, so brachial plexus, C5, 6, C7, C8, and T1. You have the upper limbs and you have the lower limbs. C8 and T1. So there's 2 types of palsies you should be familiar with. Erb's palsy, Erb's Duchenne, and Klumpke's. Erb's Duchenne, C5, 6, and 7. Remember in Erb's Duchenne, C5, so remember C3, 4, and 5 are the ones that innervate our diaphragm. So C5 is critical for breathing. All right, so you may have a kid who's having respiratory difficulty. That's going to fall, and that's the reason why when they have. So this usually happens at the time of birth when they're stretching the neck, and that pull on the neck side as they're getting the baby out causes the issue. So C5, C6, and C7. The thing with Erb's Duchenne is that you have a hand that is rotated medially, and you have the hand out to the back, okay? So it's what they call the waiter's tip hand, okay? Now, it's rotated, it hangs by the side, rotated backwards. The question is, between Erb's and Klumpke's is, what's the grasp? And in a waiter, if you put money in a waiter's hand, they're not going to let go of that money. They're going to hold on to their money, all right? So grasp is intact in Erb's Duchenne palsy, okay? Whereas Klumpke is the claw hand. This is a lower brachial plexus injury, C8T1. It's that claw hand. It's your forearm that is supinated. So you're like holding a soup bowl, all right? And your wrist and fingers are flexed. And so they have a kind of a clumsy claw hand. And if you put money there, you can easily pull it out of their hand. So the grasp is not intact in Klumpke, whereas the grasp is intact with Erb's Duchenne. All right? Hip exam, Ortolani and Barlow's maneuvers. The words tell you everything you need to know about this. So if we look at Barlow, we'll start with Barlow. B for back. So when this is like feeling at the ischial spine, is when you hold the knees and you kind of put your fingers right on the side of the baby and you rotate the baby. You're trying to dislocate the femoral head and then relocate the femoral head. If you feel clicking or clunking from that position at these fingers where you're at the hip, then it is probably a high likelihood that the child is dislocated. And we worry about developmental dislocations of the hip because if you don't treat them early, they're going to have difficulty walking. So that's why the other part of the examination, I told you, those 3 parts, the eyes, the femoral and auscultation, and then the hips are the third most important. So Barlow, if you look in the word Barlow, there's a B, and that's like pushing back and rotating to the O. Back to out. That's Barlow, so locking. And Ortolani, O is out to I, in. So you're already out. Ortolani is from out and going back in. Barlow is back and then going out. Okay, it's all within the words. All right, so back to out to in. All right, limbs, we want to look for hypertrophia, symmetry, phocomelia, and amniotic banding. And we'll go over some of the phocomelia when we talk about thalidomide exposure. Amniotic bands, you'll see these pictures. A lot of times I'll show you of the hand, and the fingers are severed at an angle, okay? And oddly severed at an angle, or you might see it across the face, a portion of the face. These are amniotic bands. Those bands can be very fibrous, and they're like threads that go through and can kind of rip through the limbs, or they have a severance of the arm at the time of birth. Last part, neurological exam, alertness, cranial nerves, motor function, clonus. This is the second part of the Ballard exam that you're going to take a look at. So here's that Ballard exam. We're looking at the different type of angles. So look at posture. Square window is when you take your hand and kind of flex it at the wrist and see how much flexion you have. Some people can take their hand and put them all the way to their forearm. I can't. Arm recoil, if you push the elbows down on the bed and kind of stretch them out, and then just hold their elbows there and see how much recoil there is. Popliteal angles, you take their knee up to their chest and kind of see the angle of the bend. Scarf sign, you have both shoulder blades touching the bed, and you bring their arm over and see how far you can bring it over. That's scarf sign. And then heel to ear is just flexion at the hip, and just kind of see how much flexion the baby has. It'll give you a neuromuscular score to help you give the second half of the Ballard exam. Reflexes, Moro, failure to abduct one arm. So remember the Moro is like kind of the reflex where you pull the baby off the bed and let him go. And they're like, whoa, like this. If there's just kind of one arm going, there's probably ipsilateral brachial plexus injury. Grasp, stepping, suck and swallow. So just kind of take a look at all the reflexes, particularly for development, in kind of determining where the baby may be. All right, so the eye, we do the erythromycin ointment for prophylaxis of Neisseria gonorrhea. Typical board question. You might put a star next to this because you will see this again. Vitamin K. There's a IV, like an injection form, not IV, sorry, but IM or oral form. Just remember this caveat: the oral form is not as effective as the injection form, and so in some states now they are looking at causing the not giving of vitamin K to the infant as negligence. And in fact, like in the state of Illinois, DCFS, which is our Child Protective Services, can be called if parents refuse to give vitamin K to the infant because of the high risk of hemolytic disease in the newborn. So vitamin K dependent factors, another place to put a star, 2, 7, 9, and 10. Just remember the year 1972, 10, 7, 10, 9, 7, 2. 2, 7, 9, 10. Of these 4 factors, the extrinsic factor is factor 7. That's on the extrinsic pathway. All the rest are either on the intrinsic or combined pathways. So factor 7 sits outside. The best way to think about it is like 7 is perfect and is ethereal. It sits above and beyond the plane, and so it's outside. Hepatitis B, must both give Hep B immunoglobulin and HBV vaccine to infants born with Hep B positive moms. Remember, you have about 12 hours to figure this out and determine what mom's Hep B status is, and then have to figure out if you need to give the vaccine plus the immunoglobulin or just the vaccine. Cord care, usually the umbilical cord takes about 2 weeks to fall off. Try to keep it as dry as possible, clean with soap and water. Remember, if it stays on for a longer period of time, we worry about leukocyte adhesion deficiency. Otherwise, really try to keep that dry at the base, and so hopefully it falls off without any problems. Circumcision, the AAP kind of placed their statement in 2012 that benefits outweigh the procedural risks for these babies, and if done correctly with a block, and they shouldn't have a lot of trauma and pain that are associated with that. Neonatal screening, newborn screen. For those that are at risk for glucose, we talked about this, about less than 50, giving the glucose gel to see if that they are having respiratory difficulties. You don't really do a screening hematocrit. That's not really routinely recommended. If mom is O-type blood or any type of Rh negative, we want to get the baby's Rh and blood type, especially if she's O-type, to see if there's ABO incompatibility or ABO hemolytic disease of the newborn. We look at inborn error metabolisms. All states have the routine state screening that we look at a lot of the underlying metabolic or congenital anomalies. Again, these screening tests are typically designed for term newborn infants. In the premature population, we get a lot of false positives. If the kid's been on TPN, if they're just very, very small, usually we have a lot of NICUs have it set up where you have multiple tests done in the first month of life to determine if they're real or not. Hearing test, the ABR and OAE, so there's the auditory brainstem evoked response, and the other one is the OAE, the otoacoustic auditory emissions test. Of these two, the first one, ONE, is the OAE, okay? So that's the OAE is first, that's the screening test. It's about 80 cents a test versus the ABR, which is about $10 a test. And the OAE really looks at the emissions generated by the cochlea. It's cheaper, but it is affected. It's not perfect. It's affected by fluid and debris, so it has a lot of problems with it. You get a lot of falseness in there. And so if the OAE fails, but it's so cheap that you just do it in the hospital, if it's noisy, it's hard to get a real accurate reading. And then if they still fail their OAE after a couple of attempts, then you send them for an ABR. That's the auditory brainstem response test. It takes a longer period of time, and it's more expensive, okay? All right. Other visual and hearing topics, deafness and syncope. So if you have deafness that occurs with syncope, consider prolonged QT. And there's two forms of inheritance. So the two ones that I want you to note is that, remember that prolonged QT, so we talked about the P wave and the Q and then the T. And so when you get an EKG, they'll do a calculated QTC interval, a corrected QTC confidence interval. And you got to be careful about, it'll say, prolonged QT may be suspected. First of all, without calipers, you can't really determine prolonged QT without properly measuring it yourself. Secondly, is that in the first week of life, infants may have prolonged QT normally, okay? It's beyond a week of life that you have to really assess them. And if you get a failed hearing screen plus a prolonged QT, then you worry about a couple forms of inheritance. So there's the Jervell-Lang-Nielsen autosomal recessive, which is associated with deafness. This is usually the KCNQI gene or KCNEI gene. They're usually severe bilateral sensorineural deficits that is there. And it takes both a longer time for the heart muscle to recharge. And so they get a really irregular heartbeat, causing that risk of fainting and sudden death. So the Jervell-Lang-Nielsen autosomal recessive. Romano-Ward is the other type. This is autosomal dominant. Usually these kids will have syncope, V-fib risk, torsades, and they usually also will have ear anomalies associated with that. Okay, so ear anomalies plus that autosomal recessive Romano-Ward. Jervell-Lang-Nielsen is the autosomal recessive side of that. So these are two syncopal/deafness diagnoses that you should be familiar with, and put it in your vault of knowledge. Okay. All right. So multiple births, increasing incidence. Greater than 2% of all births are multiples. Moms are older, and so require assisted reproduction, and it's about 25 times higher in these type of moms. And there's an increase, because there's multiples, there's an increased risk of being a premature birth then. So term infants usually, for singletons, is 40 weeks. When you have twins, term in a twin is considered almost 36 weeks, and in triplets is about 32, 33 weeks. So the increased risk of pregnancy-induced hypertension is there, prolonged rupture of membrane, placenta previa, polyhydramnios. There can be malpresentation, so you have one infant that might be breech while the other one's vertex, or both breech, or both transverse lies. Chord problems depending on the chorionicity or amnionicity. So remember we talked about the da and the MD and the, so you guys remember that, see? And so they may have, if their sacs are shared, they may have cord entanglement issues, congenital malformations, and then abruptio placenta. So conjoined twins, is that early or late? When are you confused? Late, yes. So conjoined twins happens around after the 2-week mark. Monochoriotic, monoamniotic, 1 in 50,000. Usually operative delivery, twins and triplets. Twins, about 50% require operation. Triplets, 70%. Conjoined twins may be sharing of multiple. They can be sharing through the organs together, brain, heart, liver, commonly. Other things about multiples, there are fetal growth restrictions, usually about 28 to 30 weeks. The uterus just has only so much volume it can hold, and so that's where a lot of it can be problematic. Some birth weight anomalies, we talked about SGA, AG, and LGA. Remember, when you determine classification of where they sit, it's only based on weight. So there's 3 parameters we look at. We look at weight, we look at head circumference, and we look at length, okay? And when babies are starting to become growth restricted over a period of time, these things start to go off one at a time. So weight goes down first, and then length, and then the head circumference. So sometimes we see infants that have low weight and length, but their head is spared, or head sparing that occurs. These are the asymmetrical IUGR kids. And those are kids that may have been affected. Mom was a tobacco smoker or drug use or such, and they may have, that's why the asymmetrical IUGR may be there, something from an environmental concern. or you have symmetric, where the weight, length, and head circumference are all symmetrically low. These are symmetric IUGR. Chromosomal anomalies are sometimes fit within this category. IUGR, we talked about, not all IUGR are SGA, and you gotta look at the pathology and look at potential etiologies, placental, maternal, fetal. IUGR, we look at the symmetric growth restriction, if it's intrinsic versus extrinsic, where all the parameters don't fit. As you can see, the baby on the left there, these are the same gestational age babies, but these are both 37-week gestation babies. One is IUGR and one is infant of a diabetic mom. Same exact gestational age. You can see how much variance can occur. But then you can also see a lot of the emaciation. Remember, in IUGR kids, they usually, if they're born at 35 weeks or 36 weeks, they have not had, or if they're just IUGR in general, their glycogen storage is not there. And so one of the things that when you look at glucose metabolism is that they may not have the ability to take glycogen and have glycogenolysis break down to allow glucose to be there for the body. Outcomes for SGA, so it may include hypoglycemia, polycythemia, temperature instability. Remember, perinatal asphyxia, put a star next to, because that is the one that usually is associated with a lot of the small kids because of uteroplacental insufficiency. RDS, respiratory distress syndrome, abnormal metabolism of proteins and lipids, and neurodevelopmental abnormalities. So in utero exposures, this is a new feature for NICU. We look at teratogens, drugs and medications, and maternal disease, infectious agents. And so there's a whole host of drugs that really kind of can affect the newborn. Remember that timing and exposure of drugs to the baby really makes a difference of what their developmental outcomes can be. So if they are exposed to a drug early on in life, early on in gestation, in the first trimester, there's going to be a higher likelihood that that child is going to have profound issues at the time of birth. Because of embryogenesis, as it's occurring, there might be organ developmental issues. Kids that get exposure in the second and even in the third trimester may not see nearly the effects as those that are in the first. Maternal anti-epileptics is usually a big thing. Older meds have an increased risk of neural tube defects and clefting, and so you try to change to a more newer type of anti-epileptic. Keppra being one of those examples is a better type of drug. And try to increase folic acid. There's been a lot of push with the increase of folic acid in bread and just the diet, and a lot of awareness, which has really kind of helped. Valproic acid causes neural tube defects, carbamazepine, neural tube defects, and phenytoin's written on here, hydantoin, and we'll talk a little bit about that in just a second. All right, so I'm going to go down this list. All of these drugs you should know very, very well, and you should know what it causes and how it causes. So let's start from the beginning. Thalidomide. This is kind of a drug in the early 1960s. Anybody know Billy Joel's song, "We Didn't Start the Fire"? You know, if you hear the words to the song, he goes, da da da, Harry Truman, Doris Day, Red China, Johnny Ray, da da da. And then at the end of one of the verses, South Pacific, Walter Winchell, Joe DiMaggio, then he goes, something children of thalidomide is what he talks about. And he's talking about these 1960 kids who have developed phocomelia. And so phocomelia is where they have limb defects. Their arms and legs are missing, essentially. Or they have radial and ulnar abnormalities, thumb abnormalities. They may have polydactyly or syndactyly, microtia, usually intestinal intrasias were also associated with this. So things you want to know with thalidomide. Methotrexate. So methotrexate is a oncological drug. It has a high risk of craniosynostosis, limb defects, low set ears. IUGR is another big thing for methotrexate. Cranial dysplasia is a broad nasal bridge. Warfarin. So these two things, nasal hypoplasia and stippled epiphyses on the bone, are very common to see in warfarin. The risk is higher if mom took the warfarin in the first 12 weeks of her pregnancy. Remember, heparin does not cross the placenta, so it's a much safer alternative than warfarin. But there's also a high risk of maternal hemorrhage. Tetracycline, they say tooth staining, which is true. We try not to give tetracyclines to our infants because of the enamel staining that occurs. Retinoic acid, Also, isoretinoin within that same category. These are findings that similarly mimic the 22q deletion syndrome. When you get to cardiology, you'll learn about catch-22. The DeGeorge syndrome complex is this 22q deletion. The features of DeGeorge are very much as what you're going to see in retinoic acid. So they have usually outflow tract obstructions, tetralogy of Fallot, transposition of great vessels, double outlet right ventricles. They'll have facial nerve palsies, elongated face, thymic hypoplasia, or what you're going to see. Hydrocephalus is also the other part. Lithium, put a big double star for Epstein's anomaly. This is the wall-to-wall heart. When you look at an x-ray and you see the heart go from one chest side wall all the way to the other, this is Epstein's. And what that is that the tricuspid valve is displaced down into the ventricle, what they call atrialization of the ventricle, and that's Epstein's anomaly. These kids usually have very dysfunctional function in their heart, and because remember on the right atrium is where all the pacemaker nodes are, these kids all have a higher risk of having arrhythmias because their pacemaker nodes all over the place. ACE inhibitors, think renal, anything renal, oliguria, anuria, renal dysgenesis, and then diethylstilbestrol, DES. Usually this causes a lot of the sexual organ tract maldevelopment. So in the girls, it can cause vaginal adenocarcinomas, uterine and cervical abnormalities. In boys, microphallus, cryptorchidism, and testicular hypoplasia. Fetal alcohol syndrome, microcephaly, the smooth philtrum right above the lip, short palpebral fissures, growth deficiency. These are usually very difficult to see in utero, right after birth, and recognize in infants, particularly if the infants are premature and mom have had a high risk of exposure to alcohol. These are sometimes not very easy to see, and we don't notice these differences until the child becomes closer to school-bearing age and are having a lot of developmental difficulties. Maternal diseases like maternal PKU have similar features to fetal alcohol syndrome. Maternal diabetes, we worry about neural tube defects, renal anomalies, and heart defects, and we'll talk about that in a second. All right, let's talk about TORCH and the TORCH infections. So these are the congenital infections. The earlier in pregnancy that you acquire the TORCH infections, the higher the risk of having issues, okay? So we'll go down to all the T's, all the torches, and kind of hit the highlights. So let's start with toxoplasmosis. Toxoplasma gondii is a parasite. Remember, in toxoplasmosis, the common features of toxoplasmosis are they're going to have calcifications in the brain. They're going to have blueberry muffin rash, less likely. Okay, so really the big things is calcification in the brain, microcephalus, and hydrocephalus are the three big things. And chorioretinitis, I want you to put a star, are the four things that you want to know about toxo. So microcephalus, hydrocephalus, chorioretinitis, and calcifications, all right? CMV, cytomegalovirus, is a herpes-type virus, DNA virus. CMV, the big things you're going to see are blueberry muffin rash, extramedullary hematopoiesis is huge. The other thing you're going to see in CMV is calcifications of the brain, and these are periventricular calcifications. Okay? And the other part of CMV is hearing loss. Hearing loss, and this is like the most common morbidity is hearing loss. All right? All right, so the difference between toxo and CMV, if you look at the letter C, looks like it wraps around the ventricle, so it's periventricular. Toxoplasmosis, T, is totally throughout the head. So it's total intracranial calcifications. CMV sits around, like imagine the letter C coming around the ventricle, is CMV, periventricular calcification. Toxo is totally throughout the head. Rubella, all right, so so the things you need to know is the hearing loss is one part, but cataracts, machinery-like murmur, which is from the PDA, and blueberry muffin rash. extramedullary hematopoiesis. So we're starting to see some traits here. So toxo and CMV share maybe some chorioretinitis, but they really share the calcifications, but they're different. Rubella and CMV both have the blueberry muffin rash, which is the extramedullary hematopoiesis, but rubella, you're going to hear either about a machinery-like murmur or a washing machine murmur or just a murmur and cloudiness in the eye. So any of those combinations will be rubella. CMV, the combinations will probably be calcifications plus, or they'll say the kid has got profound hearing loss plus the calcifications that are there. Let's talk about syphilis. So we talked a little bit about syphilis. I had you remember the pictures that we saw earlier about the snuffles and the ragades. The other parts about syphilis is, so there's early onset findings of syphilis and there's late onset findings of syphilis. So early syphilis, you'll have kind of you have the palms and soles rash. There's only a handful of things that causes a palms and soles rash. You may get some swelling of the fingers or dactylitis, okay? We talked about the snuffles. This is an early finding, okay? The ragades are also an early finding. Some of the late findings are the saddle nose. And so the saddle nose is complete erosion of the bony nasal material. And the way to think about it, and not that it happens this way, another just way to think about it is that if you imagine you had a really bad runny nose and you wipe and wipe and wipe and wipe and wipe, and you wipe it down so much so that you erode the bony nasal portion, you get saddle nose. Not that it happens this way, but that's how you can remember early from late. And then the teeth findings in syphilis usually are later. There's 3 types of teeth that you should know. One is the Hutchinson's tooth. Those are the Fred Flintstone body. Everybody remember the Flintstones? This is like the barrel-shaped body with a central little notch. So if you imagine a barrel with a little notch in the middle, those are Hutchinson's. Those are in the central incisor. They're the mulberry molars. And these are the molars that you have. They are splayed really wide open that a mulberry can fit on top of that. And I would encourage you to take a look at all these pictures online just to kind of get a visualization of them. And then the third part are their enamel abnormalities of the tooth. And so those are the 3 tooth findings that you want to know about syphilis. Okay? Varicella would probably fit under the other. These are the limb hypoplasia, scarring, chorioretinitis. Parvo B19 fits in the other. Congestive heart failure, high drops. It really depends when you get Parvo B19. It's a very interesting bug. And Zika is probably the more newer one, causing the microcephaly of the newborn. So these are your torch. Now, the other thing I want you to put a big star next to all the torches, as these all cause direct hyperbilirubinemia. Okay, and when we talk about jaundice, we will talk about indirect and we'll talk about direct. The most common cause of direct hyperbilirubinemia is torch infection. So the most common cause of direct hyperbilirubinemia is infection, 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 and infection. Oh, one more, infection. And infection. And torches are the ones that I want you to think about. So when you get a vignette and you look it on your boards and it has direct hyperbilirubinemia in all the 50 million labs, you're like, oh, they want me to think about torch and start going down that pathway, all right? So torch infections, keep that in mind. All right, so you were evaluating a newborn infant in the nursery. She was born at 32 weeks gestation after a placental abruption. Mom had poor prenatal care and reports that she takes warfarin due to a history of deep venous thrombosis. Mom's 42, dad is 50. Wow. Most likely physical finding for this infant is A, neural tube defect, B, intrauterine growth restriction, C, Epstein's, D, nasal hypoplasia, or E, absent limbs. Nasal hypoplasia, very, very good. Excellent. All right, so infant had exposure to warfarin, exposure 6 to 9 weeks gestation causing fetal warfarin syndrome, nasal hypoplasia and staphylopeplexes. Remember, neural tube is more associated with the anti-seizure drugs, carbamazepine, valproic acid. Many fetal exposures and maternal conditions are associated with poor fetal growth. Epstein's anomalies, lithium, we talked about that, and thalidomide, the missing limb defects, usually at 34 to 50 weeks gestation, 50 days gestation. All right. All right, let's go to the glucose stuff now. All right, infant of diabetic mom. So these are the big kid infants, but I also want you to remember the small infants, which I'll show you a picture of. So the IDM moms, so the preconceptual glucose levels will really kind of determine how severe and how well controlled mom's glucose is over the course of her pregnancy will determine kind of how bad the effects will be for the child. Maternal hyperglycemia causes fetal hyperglycemia, but then the fetus is like, their insulin is not going to come from mom. It's going to come from their own pancreas, so their pancreatic beta cell hypertrophy occurs, and they get hyperinsulinism. And once that cord is cut, now it's mom no glycemia coming through, and they have hyperinsulinism. And so that hyperinsulinism is going to drive the glucose levels to get very, very low until we get balance. So increased glucagon, increased epinephrine, increased growth hormone, decreased insulin are the changes that occur at birth. One of the clinical outcomes is there is sudden chance of fetal death. It's about twofold higher, and it's usually from a placental diffusion defect and impaired fetal oxygenation. So it really requires a lot of surveillance. If the babies get too big in size, just because their organs get bigger and the baby gets bigger in size doesn't mean that the organs function any better. And this is the thing I try to drive home with the parents is that your child might be at 12 or 14. Just last week I had a kid, was 15 pounds, was not born vaginally, it was a C-section, but a 15-pound baby, and it was like a two-armor already, you know. But that kid was in severe respiratory distress, was in, you know, not only we had glucose issues, but, you know, I'll explain the respiratory distress in a second, but had a lot of other complications. So just because the larger baby did not equate to stronger baby, okay? Their heart can not be functioning well, their liver is not functioning well, so this infant was in cardiac failure, and also was in respiratory distress. So macrosomia, there's a high risk of trauma and birth trauma. Usually they have a large liver, large heart, and the brain has reduced brain iron, and they're usually not very good feeders. They're like kind of like lazy, sloppy babies. And they don't know what to, you're like, you have all this food on board, like that post-Thanksgiving, you know, comatose feeling you have sitting on the couch, you're like, oh, you know. Well, that's what this baby is. Has been enjoying it all for however many weeks inside mom. So hypoglycemia is there, blood glucose less than 40. We really, you know, babies tolerate low glucose really, really well. If their blood sugar is like 20, 25, they get a little bit jittery, but they kind of look at you like, okay, you're going to feed me or do something, you know? If ours was down to 25, we'd be like on the floor, kind of passed out completely, you know? So call somebody. So they really, but it doesn't mean that, you know, we just leave them like that. It has a higher risk of having issues to the brain, and we want to get that blood sugar up and get it monitored early and more consistently. And so sometimes you got to require to give glucose. Remember, when you're given a glucose infusion, in a peripheral line, you don't want to give anything higher than 12.5% concentration because of the osmolality differences. It has to be a central line then, so you got to get an umbilical venous line in or a PICC line in if you want to use D12.5 or greater. So D15, D20, D25, D50, whatever the case, to get that sugar level up. Hypocalcemia is one of the other complications. Parathormone and placenta is usually accompanied with a low phosphorus and mag. Usually the infants are very jittery. They can have prolonged QT issues, conduction abnormalities, so IV calcium gluconate. When you give IV calcium gluconate, do it slowly because you don't want it to extravasate into the tissue. It'll cause a massive burn. You want to give a nice amount, very, very slow, so that it infuses properly. Hyperbilirubinemia, these kids are polycythemic. When we talk about the jaundice, you'll see that as the heme breaks out, it releases a product of bilirubin, and so these kids are going to be at high risk of having jaundice. Rarely do they need partial exchange. However, if their blood concentrations are greater than 70, so that hematocrit is 70 or greater, you may consider doing a partial exchange transfusion slowly to bring that count down. You don't want to take it out suddenly because the kid can go into high output cardiac failure as well. Respiratory distress, there's a lot of reasons, but the biggest reason is that it shuts down and inactivates the surfactant proteins. So that high exposure to glucose really makes the surfactant turn off. And so these kids are these big term kids that act like a premature baby and require surfactant dosing. And so that's one of the things to consider and remember is that, you have a 39-week infant who's, 16 pounds and like chugging away, grunting, and you get an x-ray and there are hazy lungs bilaterally, you might want to drop a dose of surfactant there to help this child out. Congenital anomalies. So the other part I want you to look is the kid on the right there. So you have the large baby, but then you can have the really restricted kid who hasn't gotten the nutrients, and this is a kid who's got caudal regression syndrome. Okay, so this is like from head to about here is probably relatively normal, and then it just regressed. And now this is not as severe, but I've seen cases where it almost look like flippers at the bottom of the feet. Okay, and just a single like fin. So just whether it's complete regression as the child went caudally, cardiac anomalies, VSDs, transposition, neural tube defects, put a star next to small left colon syndrome. Think about this in an infant and diabetic mom. They love asking this on the boards about what's a common GI complication of small left colon, gastrointestinal atresias, and abnormal genitourinary anomalies. All right, so postnatal risk for the infant born to a later onset, poorly controlled gestational diabetic mom include all the following except. So remember, this was kind of designed to a little bit trick you. It's a later onset, poorly controlled. When is caudal regression syndrome really going to hit? It has to be early. It's going to be in the embryogenesis period. So that's when your preconception glucose was really, really poor and out of control. That's when these kids are going to be at highest risk of having caudal regression syndrome, because in those first 12 to 14 weeks of gestation, the development didn't get a chance to occur properly. Hypertrophic cardiomyopathy you're going to probably see a little bit later, hypoglycemia and hyperbilirubinemia because of the blood counts. Okay? All right, let's go to respiratory. So neonatal respiratory syndrome, or respiratory distress syndrome, hyaline membrane disease is the old terminology, RDS is what you might hear. This decreases with advancing gestational age. So remember, RDS, usually at 34-ish weeks, the alveoli are present in enough abundance and the surfactant is pushed that usually as you get past 34, 35 weeks, the lungs are mature. This is not always true, though. Remember, the body has to go through some underlying responses of catecholamine to get the body ready to be ready to be out in the outer world, and so that surfactant has to get kick-started in. And so sometimes, particularly moms that have not had a stress response, so moms that may have suddenly got preeclampsia, baby getting sick, and they have to deliver, or 15 years ago, the en vogue, I want to have my baby delivered at 37 weeks or 36 weeks because I don't want to be pregnant anymore. So I just make an appointment and go to the OB and say, all right, let's take the baby out. Well, baby wasn't ready yet either. So these are the kids that did not go through a lot of that, stress. Their body's not ready yet. They're going to have a high risk of having surfactant deficiency. White males, no antenatal steroids. And so we always look at surfactant. Now, surfactant is kind of broken down. It's mostly a lipid. It's mostly that dipalmitoyl phosphatidylcholine. It's about 70% of all the surfactant is that. There are different types of surfactant apoproteins that exist, A, B, C, and D. The A and D are both hydrophilic, and the B and C proteins are hydrophobic, okay? The surfactant type B, it's in green because that's the most common type that we're going to deal with and the one that you probably need to be most familiar. And unless you're going into neonatology, I wouldn't worry too much about too many details, but remember that they come from type 2 alveolar cells. The phosphatidylglycerol usually increases after about 34 to 35 weeks gestation, and it really more accurately reflects lung maturity. So when you think about phosphatidylglycerol, put in parentheses lung maturity, because as phosphatidylglycerol increases, your risk of RDS should decrease, okay? But it is not necessary for normal surfactant function, all right? And then you can see a Laplace's law there of looking at the pressure, and it's a relation of the surface tension and the radius. So it's 2 times the tension divided by the radius. So, really without surfactant, as alveoli increase in diameters, imagine a room. So if we had a room that was the size of the stage and had 100 people on it, and the room that's the rest of this room and had 100 people in it, as people come filtering in, they're like, I'm not going to go on the stage. There's way too many people on there. It's going to want to go to the area that is already larger. And what happens in physiology with these is as those balloons get larger and larger, it allows more air to go through because it's a path of least resistance, and the adjacent balloons get smaller and smaller in size, okay? So you get this kind of VQ mismatch that occurs. Risk factors: gestation, male gender, Caucasian, infant or diabetic mom, second twin, family history are the big risk factors. So factors which may reduce the risk of RDS, so usually anything that will cause fetal stress to augment or accelerate the catecholamine response, those are going to probably reduce your risk. So maternal hypertension, premature rupture of membranes, subacute placental abruption, maternal use of narcotics, subacute choreo would help reduce that risk. So when we look at the lecithin to sphingomyelin ratio, so that's the LS. So let's talk about the sphingomyelin portion first. This is the membrane lipid that decreases after about 32 weeks gestation. This is not related to maturity. And lecithin increases with gestational age. So lecithin really reflects maturity. So as your gestational age increases, your lecithin should increase. So they do a ratio of L to S. And so if that L to S ratio is greater than 2, it probably gives a good indication that your lungs are pretty mature. And if you need to deliver, you could probably deliver. We talked about antenatal steroids. It's best to be delivered after 48 hours and days after given. Usually the recommendations is between 22-ish, 23 to 33 weeks. You give the antenatal steroids. You try not to give more than 2 doses or 2 courses worth because of risk of brain development. But up to 2 courses seems to work pretty well in both stabilization of the brain as well as augmenting the lung response and getting the baby ready for delivery. So RDS, remember the clinical course often shows progression over the first few hours. The hallmarks of RDS are 3 things. And so this is what I want you to remember from on X-ray. So they're hypoventilation, so decrease aeration in the lungs, ground glass appearance, so equal kind of hazy distribution on both sides of the lungs, and air bronchograms, all right? So air bronchograms is like when you look at an X-ray and you can see you have the trachea, you have the primary, secondary bronchus. When you get out to the tertiary and quaternary chains, you start to see those well-delineated like little pathways, and that's all that debris that kind of comes up against the airway and makes those look very clear on the X-ray, okay? So hypoventilation, ground glass, and air bronchograms. These are the 3 hallmarks on X-ray features for RDS, and I'll show hopefully a picture here. Diuresis precedes recovery. Remember, once you kind of get that lungs to be dosed with surfactant, the surface tension decreases, and as that surface tension decreases, you need to allow the breath to be taken a little bit more easily. You need to back off on the pressure. So complications, pneumothorax. If you don't back on, you can see the pneumothorax in through here. You can get chronic lung disease. We try to do general ventilation. So really diagnosis, premature signs of the tachypnea grunting. Here's that hypoventilation, usually 7 to 8 ribs in excursion. You have this kind of ground glass appearance, and you can kind of see in through here and down here, those air bronchograms, okay? So we want to prevent saccular collapse. A lot of times now what we try to do is early CPAP to really kind of keep that airway open and avoid atelectasis to occur. And if you can avoid the atelectasis, you could probably go into a phase of non-invasive ventilation. We are trying everything we possibly can to not intubate babies anymore early on. In fact, I have 23, 24 weekers that we don't intubate from the get-go. We at the time of delivery, when we're doing our delayed cord clamping, they get delivered. We have a CPAP mask that we put on while they're still attached to mom on the cord. So we're providing positive pressure to the baby, and then we do the delayed cord clamping is occurring, and then we cut the cord, and then we just transition them over. And a lot of times, a lot of the centers are now doing this Ensure, where if we need to give, we intubate, drop the surfactant down, and then extubate and place on back to CPAP. And so what we've done over the last 2 or 3 years, particularly with the non-invasive, we use nasal mechanical ventilation, and we've now taken our chronic lung disease rates down from 40%, 45% to about 20, 23%. So we've made a number that nobody really thought could be changed over the last several decades. We're now finding new ways of doing that. And a lot of the market that is out there is looking at inhaled surfactants, so that you don't even have to intubate to put the surfactant down. So the technology is still continuing to push forward. So surfactant with prophylaxis versus expectant, usually trying to determine what your threshold is before you need to give that surfactant. FiO2 usually greater than 35% is usually that the caveat, or if they're escalating in their respiratory support. When we look at mechanical ventilation, the whole idea is to minimize the volutrauma and barotrauma that occurs. So we target a volume about 4 to 6 ml per kilo. This is the type of ventilation we use, a volume guaranteed ventilation. So rather than dial in a pressure, we dial in how much volume we want, and we let the babies kind of determine how much pressure they need. The key about this that you need to kind of keep an eye on is as you dial that in, you need to keep an eye on that positive inspiratory pressure, because if it takes a pressure of 20, 25, 30 to get that 4 to 6, it's too much pressure for them. And so you might need to back off and change the modality of that. We allow permissive hypercapnia, and I don't want to get into too much detail with a lot of the respiratory mechanics, but in permissive, we allow PCO2s to be elevated. Babies tolerate that well. When the PCO2s are too low, below 30, there's not enough perfusion going to the brain. That's a problem. But PCO2s at 50, 60, 70, babies do relatively well okay as long as their pH is all right. Then there's modalities of high-frequency ventilation, the oscillator and the jet ventilators. These are providing high pressures at very low volume. So the problem is like, imagine a football in a pressure volume loop. You want the pressure to kind of go in, hit a certain amount, and then volume to come back, and volume to increase, and then come back down to baseline. So it looks like almost a football on its side. If the pressure gets too high and you're giving way too much pressure and the volume's not increasing any further, you get kind of what this bird beak sort of pattern. And that extra amount of pressure is causing extra stress. The best way to think about it is take a balloon, have a child blow a balloon, and have them inflate it up. You can blow to a certain amount, but if you put a little bit more air in the balloon, it can probably get a little bit bigger. And you put some more air in the balloon, it can probably get a little more bigger. So if you imagine if the fibers of the balloon are completely collapsed, you blow it, and at full it's like this. And then you blow it a little bit more, and you blow it a little bit more, and it's stretching, and it still hasn't popped yet, and you blow a little bit more, you'll get to an optimum point that if you put a little bit more air in there, poof, it pops. But right before then, if you stop and you let the air out of the balloon and deflate, does the balloon hold the same integrity? No. It's stretched completely. So it's going to have a misshape inside, and that's what happened to the alveolar sacs. That's volutrauma. That's too much volume in that area that you're caused excess stretch. Okay? And if you put too much pressure in there, they're causing barotrauma. All right, so other respiratory diseases, TTN, transient tachypnea of the newborn, retained fetal lung fluid, C-section typically without labor. Usually these are the kids. A lot of times they said that, if the baby was born via cesarean section, they're going to be at high risk of TTN because they didn't get squeezed through the birth canal. That's complete garbage, all right? So the reason why the C-section kid probably hasn't gone under any stress, their catecholamine response hasn't kicked in, and so there's going to be some retained fetal lung fluid because the baby wasn't ready to come out. You'll see the same effect in a precipitous vaginal delivery, where the baby hasn't gone through the cardinal movements of labor and pop right out because mom's G12 or whatever. And so she pops this baby, like she walks in and just coughs and the baby comes squeezing out. Kids are probably going to have some TTN, okay? So those cardinal movements or that stress period allows the body to get ready and do what it needs to do before they're ready to be born. So TTN's kind of got that sunburst appearance on the x-ray. As you see here, hazy fluid, some fissure in the diaphragm. You can kind of see a little bit of fluid that's kind of outlined right here. It usually resolves within the first 24 hours. Persistent pulmonary hypertension, this is the persistent fetal circulation that we talked about before. This is the higher pulmonary pressures that are in the lungs. You get shunting that occurs because there are higher pressures. It's clamped off, so the blood doesn't want to go there. And then because it's deoxygenated blood, it's going to cause hypoxemia. There are a lot of etiologies that causes pulmonary hypertension. The x-ray that's common that you see are either very clear lungs, okay? Most likely very clear lungs like this, because there's no blood flow going through there. All the blood is getting shunted off to somewhere else. And so, or you may get an etiology where it's meconium aspiration, similar to this one. And in meconium aspiration, remember the meconium plug gets into the distal airway, and as it bifurcates and it gets plugged up, it works as a one-way valve. Air goes in, but doesn't come back out. So as air goes in, just like with the concept of the large room, air goes into this, the alveoli on this side gets really big. The alveoli right next to it's like, where's everybody going? They're all going to the party, right? But the air can't come back out, and so the adjacent alveoli gets very small. So you get adjacent areas of hyperinflation and hypoinflation. And so you get areas that are hyperinflation, which are going to be dark on x-ray, and hypoinflation, which are going to be like the white areas. So they get that shotgun appearance or the honeycomb appearance on the x-rays. Lung hypoplasia, congenital diaphragmatic hernia, hypoglycemia, cardiac obstructions, etc. So remember, this is a failure in transition from fetal circulation, labile cyanosis, tachypnea. Usually the diagnosis really kind of depends on what your underlying etiology is and the exam that you would do. You need to treat the underlying cause. So pulmonary vasodilators, oxygen, oxygen, oxygen. You want the pulmonary pressures to drop to allow blood flow to preferentially go to the lungs. So you target probably a little bit higher saturations. You try not to overventilate these kids, and nitric oxide really kind of helps deliver. It's a gas that works really effectively. It helps kind of vasodilate through the NOS pathway and allow that oxygen to get to the distal airways to get better blood flow. So here's the pathway, endogenous nitric oxide. Oops. As you see here, comes from formed by L-arginine and in the endothelial cells that line in blood vessels, and then it diffuses to the adjacent vascular smooth muscle. And as it diffuses, it activates cyclic GMP. And as it activates, it decreases then, it causes the vasodilation by decreasing the vascular tone. And so the nitric oxide binds to the hemoglobin then, and then becomes like NO2 or NO3, and then that becomes deactivated again. So this is the pathway that is used for that. It's a smooth muscle relaxant, helps selectively dilatate, that are ventilated. Complications are methemoglobinemia, and you have to check this level every couple of days to make sure that you're not having methemoglobin toxicity. And if it's really bad, then you just go to ECMO. Here's that shotgun appearance of meconium aspiration. Remember, it's going to be seen in more of the post-term infants, or once the infant passes their first meconium, they're at high risk. It's a particulate matter. Once it gets into the lungs, it causes a massive inflammatory response. And so these kids can have a really kind of a chemical pneumonia. It's a one-way valve, so as it goes in there, air goes in, doesn't come out. Sometimes you need to give a nice hefty dose of surfactant just to kind of wash everything out to prevent any issues. These kids are at high risk of having pneumothorax. So here's the pathophysiology. Meconium in the airway, inflammation. You get pulmonary vasoconstriction because of the hypoxia. You really kind of get elevated PPHN. You get that ball valve effect, air trapping causing the VQ mismatch, which causes hypoxemia. You get obstruction, which causes atelectasis, which causes hypoxemia. You get surfactant dysfunction because the meconium particles will inactivate the surfactant. Again, another reason why you would give the surfactant, which causes protein leak, VQ mismatch, hypoxemia. All roads lead down to hypoxemia here, so not a good thing. And so really, diagnosis if there's presence of meconium. Here's that pneumothorax in this kid. Hypoxemia, patchy infiltrates, you get a lot of air leak. These kids really require general ventilation. So you can if you need, especially they require higher pressures, so high frequency ventilation with high pressures to really relieve some of the stress with low volume. So treatment for the PPHN, oxygen support, general ventilation. If you get yourself in a lot of trouble, antibiotics usually. Surfactant, I usually dose them with a 1.5 times surfactant dose. And then if you really are in trouble, then ECMO is the alternative. All right, so meconium aspiration invariably leads to pulmonary hypertension, can be prevented via careful tracheal suctioning postnatally, is caused by bacteria found in fetal stool, or can occur antenatally. Yes, so it doesn't always lead to pulmonary hypertension, thankfully. I mean, there are cases where you're going to see it more, but it can occur antenatally. So a lot of these times is that typically, and this is the problem that, all residents get afraid when they get to a delivery room by themselves and and the OB yells out, "Hey, I think I got a meconium staining here." How your heartbeat starts to go up a little bit, your sphincter starts to tighten a bit. You're like, oh my God, what if I don't get the intubation? And the problem is that a lot of times that particulate matter, when it's swallowed, usually that first meconium is passed in utero, and that last couple of hours when that stress is there, and that particulate matter has already been swallowed, so the damage has already been done. So I usually that's why the recommendations is push towards A, B, and C. Just get the airway, get the breathing going, and get the circulation going. Don't worry about tracheal suctioning, and if you get it, and if you actually get something out, because even if you did get that, the chances that the child did not have significant response in their lungs is probably, the damage already has happened. So it really kind of alleviates a lot of the stress that way and makes sure you do the right things in resuscitation. All right, air leak, pneumothorax, air between the parietal and visceral pleura. You can see it through here. This is that sail sign where you get air in the pneumomediastinum causing the thymus to be pushed up. Risk factors, meconium aspiration, RDS, and congenital diaphragmatic hernia. Usually, they all look like the same. They all have the tachypnea, they all have the grunting, they all have retractions. You may transilluminate the chest. This one's, I wish they were all that easy, where just the half side light ups like a Christmas tree. Usually, when you put it on a 25-weeker, it lights up the entire chest and the belly down into the scrotum. And so it's like putting your stethoscope right on top of the middle of the baby, the 24-weeker. You can listen to everything in one shot and not have to move anywhere. Air leaks are there. Remember, with the pneumothorax, we want to do premium, no nocere, do no harm first, right? So oxygen washout is really not recommended anymore. If you need a needle aspirate, it's over the fourth intercostal space. Make sure you go above the rib, above the rib, so you avoid the neurovascular bundle that's below it. Pneumomediastinum, really don't do anything. It's not like you're going to put a needle in the middle of the chest to try to drain that spot. And so just really supportive care for those kids. Pulmonary hemorrhage, thankfully they're uncommon in the term infants. Preterms are going to have a little bit higher risk, particularly the very, very small. A lot of different modalities are used to try to kind of squelch the pulmonary hemorrhage, increasing the positive expiratory pressure. The PEEP is probably one of the common ways of using. Sometimes you can drop a little bit of epinephrine down the ET tube to kind of help with that. But it's usually a problem. Suction, surfactant, increasing PEEP are probably the biggest things. Wouldn't worry too much about it. All right, Group B strep. We kind of talked about the algorithm about this already. There's early onset and late onset. Early onset most common, 2 to 4 per 1,000 births. Late onset, 3 to 4 weeks. A lot of it's from the ascending infection, from the triple I, that inflammation, infection that occurs. Preterm infants. Presentation of early onset in the first to second day. Most present by the 12 hours of life. Generally, they have respiratory symptoms and escalates to a full-blown sepsis syndrome. Usually you want to do some lab workup, CBC, blood, trachea. They might have leukopenia, thrombocytopenia, abnormal coag panels. Know the GBS guidelines. They will test this very much, and it hasn't very veered much. That algorithm that they have that we saw early on, if you can follow that path and know that by heart, you'll be fine. All right? So really, we try to refrain from doing a lot. Observation, 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 limited evaluation, and antibiotics only when necessary. So the antibiotics we use are penicillin, less than 1 week, divided Q8. Greater than 1 week can be divided Q6. For sepsis, 10 to 14 days, pneumonia, 10 to 14 days, and meningitis, 2 to 3 weeks. Congenital heart disease, these are the 5 T's. The best way for learning the congenital heart disease, it's all within your hand, okay? So if you take the first number is truncus, all right? So truncus arteriosus, like a big trunk. And then if you take 2 fingers and cross over, that's transposing over, transposition. And then 3 is tricuspid atresia. And then 4 is tetralogy, because it's 4, tetralogy of Fallot. And 5, TAPVR, total anomalous pulmonary venous return. All right, and if you turn your hand around, you have a palm, that's pulmonic atresia. All right, so now you have all 6 cyanotic heart diseases. So truncus, transposition, okay, which is probably the most common type of cyanotic heart defect, tricuspid atresia, tetralogy of Fallot, and tetralogy of Fallot has 4 components, right? Pulmonary stenosis, you'll learn all this, but you want to prove that you have tetralogy of Fallot, P-R-O-V, with small e, E silent, prove. So to prove it, pulmonary stenosis, R, right ventricular hypertrophy, O is overriding of the aorta, and V, VSD. Okay? If you think VSD, what has an E at the end, that's how the prove for prove is. So tetralogy of Fallot, P-R-O-V, and then T-A-P-V-R, and then pulmonic stenosis. So those are the cyanotic heart diseases. Left-sided lesions, hypoplastic left heart syndrome, coarctation of the aorta, severe aortic stenosis. Common anomalies are ASDs, VSDs. If you look at congenital genetic defects, so many of them are VSD. VSD, VSD, VSD. Most common heart defect in a Down syndrome kid is VSD, not an AV canal defect. Most common diagnosis for a child that is diagnosed with AV canal is trisomy 21. So know the subtle difference between that. So most common defect, genetic anomaly for a kid that has AV canal is trisomy 21, but the most common heart defect in a Downs kid is VSD. Okay, trisomy 18, trisomy 13, ASDs and VSDs are very common. So really kind of know the different heart defects that link with the different genetic anomalies that might help you out. The PDA, this is very controversial. I would be very shocked if they threw this on your boards. Know that it is a machinery-like murmur. Know that it's going to be heard most commonly in the mid-clavicular upper left sternal area. That it has bounding pulses, wide pulse pressures. Typically, the PDA can cause overcirculation, but the management's very controversial. They won't ask you, like, what meds do you give? What do you do with it? We just don't know. Do you do ligation? Do you not do ligation? We do know that we have the cyclooxygenase pathway, so ibuprofen and Tylenol now, acetaminophen are used to help with bringing, so acetaminophen and ibuprofen are used to kind of help close the ductus, and if the infant has a lot of issues, then you can do ligation, but there are outcome issues with ligation. All right, meconium plugs. 90% of newborns pass meconium within the first 24 hours. If you don't have a stool in the first 48 hours of life, that's a bit of a problem. Can't send the kid home. And so really need to kind of evaluate to make sure that they're not stopped up or they're having a meconium ileus or meconium plug. You do a contrast enema, lower GI in some institutions, or a soluble wash enema, diatrizoate enema if on the boards, because nobody ever uses that terminology except the boards, and you'll see it and you're like, what the heck is that? And so that's the water contrast soluble enema. Whose effect is small left colon syndrome, which we see in kids with diabetes, right? Rectal Hirschsprungs, maternal drug abuse, prolonged magnesium. So if mom's been on mag, the bowels are going to get really, really slow, and they might have feeding difficulties early on. Meconium ileus, remember we talked about if you find a meconium ileus there, you must assess this kid for cystic fibrosis. And typically we do the sweat test once they're above 2 kilos. Less than 2 kilos, you can't really do a sweat test, but they really need to be assessed for cystic fibrosis appropriately. Usually the meconium ileus, they'll have a doughy, distended abdomen. They can't pass their meconium. Bilious emesis is a lot of times what you'll hear about. And then when you get a KUB, they'll show some intra-abdominal calcifications that are present there. Necrotizing enterocolitis, this is it's like one of those bad 3-letter words in the NICU. You never say it out loud. It's the diagnosis that must not be named for those of you that like Harry Potter. We really try not to talk about it, but it's common in the distal ileum and proximal colon. Typically, we see this in infants that are premature, between 32-ish and 36 weeks gestation, usually about 3 to 4 weeks of life. Has a pretty complicated pathophysiology. We don't quite understand why it occurs. There's a lot of theories as to how it occurs, and there's a lot of research that is being done to try to determine the etiological causes. Kids that are congenital heart disease, neural tube defects, the triple I kids, they are also at risk of having, and those kids that require it in term, unfortunately, that neck seems like it's more insidious in nature. This is a common belly presentation. That's that shiny, distended abdomen with low bowel sounds. They'll have bloody stools, hematochezia, large residuals, temp instability, increased apneas and Brady's, perforation. But if you see that taut, tense abdomen, this is where you need to do a lot of things. So first thing you're going to do is you're going to turn your fluids up. You're going to go up to about 120 to 150 ml per kilo and shut off the feeds. Second thing you're going to do probably is put a nasal gastric tube down to decompress the belly, like a Rapogl or so, and then you call the surgeon. And then probably just start the cultures and then do your antibiotics, probably do triple antibiotics. But fluid resuscitation to the bowel is critical. All right, so radiographically, there's a handful of signs. They have a football sign, it looks like a football sitting in here. They have the pneumoperitoneum. If there's a dissection of air that's in the system. There's portal venous air, and here's like how you can see that portal venous air that's through here. If you catch the portal venous air, it's very short-lived, but it's pathognomonic. It's like a slam dunk diagnosis for it, but it's very hard to tell. Pneumatosis intestinalis is the railroad track. It's that air that dissects into the intestinal lining. So management is typically no feeds for about 7 to 10 days. Sometimes they require surgery. And once they require surgery, there may be a high risk of strictures afterwards, a lot of acidosis, thrombocytopenia. All right, now we have gastrointestinal disease, and I think this is the last, jaundice is the last piece of the puzzle here, and then we'll be done. So hyperbilirubinemia is really kind of primary from hemoglobin breakdown and caused from impaired conjugation. Remember, we really don't know what the function of bilirubin. It really has no really physiologic function. Some people believe it works like an antioxidant. The placenta can remove indirect bilirubin, but it doesn't remove biliverdin very well. And we'll kind of go through this pathway. And this diagram is a very well done diagram that kind of goes through the rest of the physiology. So you have catabolism of our red blood cells, and then your bone marrow and heme and liver kind of produce about some of the heme. And so the heme is kind of, the 100% is kind of broke down 3/4 from the breakdown of the red blood cells, and about 1/4 from the ineffective erythropoiesis from the bone marrow. So that heme and globin kind of come together, and through heme oxygenase here, makes biliverdin. And then biliverdin goes through a biliverdin reductase right here at this level and becomes bilirubin, okay? So you got heme oxygenase to make biliverdin, and then biliverdin reductase to get bilirubin. And so bilirubin lives in a handful of different forms. There's a free unconjugated form. Well, we look at bilirubin two ways. They're either conjugated or indirect, or unconjugated or indirect, or conjugated and direct, okay? So there's indirect hyperbilirubinemia and direct hyperbilirubinemia. The unconjugated free bilirubin that exists is most readily present, and it most readily crosses into the blood-brain barrier. That's a problem. And we'll talk about kernicterus and why we worry about bilirubin in the first place. But it's that most readily crossable pattern is in the free unconjugated. The ones that are not free, that are actually bound, they're bound to something, and they're bound to albumin. And this is usually disrupted, this binding. It's good when it's bound to albumin because it's like linked with a partner. And albumin is like the parent. They kind of watch over bilirubin, make sure they don't act like crazy and go to the brain and cause problems. And so this albumin-bilirubin bind is disrupted by 3 things. if the child is hypoxic, if the child is hypothermic, or if the child is acidotic. Well, when do you think that happens in a premature infant? When they're first born sometimes. They're both hypoxic, hypothermic, and then they have acidosis. Well, that causes the bilirubin to be all crazy and say, all right, party. Let's go have a fun. And so that's where it can cause a problem. That's why the bilirubin is a really big challenge in the first couple of days. And then the other part is conjugated, and that's the water-soluble bilirubin, okay? So now we have the bilirubin and the albumin, and then they get kind of hooked together. So when it's bound to albumin, it can't cross the blood-brain barrier, and then it goes to the liver, and then bilirubin then binds to ligandin, okay? And so ligandin then enters the hepatocyte, and it gets then transported to the smooth endoplasmic reticulum, and then glucuronyltransferase is the next enzyme that conjugates this bilirubin to make bilirubin glucuronide, and then that is excreted into the small intestine, and then that gets deconjugated over a series of many different things by beta-glucuronidase, and then that gets reabsorbed in the stool, and that reabsorption is that enterohepatic circulation. When bacteria from the small intestine, the large intestine kind of hits this area, it reduces this to a urobilinogen, and then that urobilinogen is then excreted out in the stool process. And that's how the metabolism of bilirubin. So really secondary to increased RBC fragility, high hematocrit count, decreased clearance, and enterohepatic circulation. So as we talked about, the unconjugated is lipophilic, and a majority is reversibly bound to albumin, but the free unconjugated are the party animals. They're not bound to anybody, and these are the ones that can cross into the blood-brain barrier. The conjugated are water-soluble, and these can be excreted by the kidney and the biliary tract. So either you have an overproduction or a reduced clearance, or from enterohepatic circulation. So overproduction is hemolysis. And so these are when those red blood cells, remember the baby's hematocrit count in utero are probably very, very high. So the hematocrit count's not uncommon to be in the 60s and 70s. And then after birth, there's a quick transformation, and a lot of that fetal hemoglobin starts to cycle through, and there's a lot of fracturing of cells, releasing the product of bilirubin. And so immune-mediated, they're blood group incompatibilities. That's why we watch if moms are O positive. We want to make sure that the infants are doing okay. And if they're B or A, or AB. There may be some major incompatibilities, ABO incompatibilities. If there's an RH incompatibility, that may cause some increased hemolysis. The non-immune mediated are enzyme deficiencies. G6PD is the common one. Pyruvate kinase is a rare one. You may have structural defects. These are spherocytosis, elliptocytosis, ovalocytosis that can cause this indirect elevated bilirubin level. There's decreased clearance from the hepatic side, so it's impaired conjugation. This is the breastfeeding jaundice, okay? So this is like a low volume that's there. Decreased hepatic uptake, so Gilbert's is the most common. You've seen it in about 5% of the population, and this is a decrease in bilirubin UDP. There's also the handful of enzymatic. There's Crigler-Nahar, and then you'll hear about Dubin-Johnson and Rotors, okay? So if you think about Dr. C, DRC, D is Dubin-Johnson and Rotors, those are conjugated hyperbilirubinemias, and that leaves the other two, GC, Gilbert's, and Crigler-Nahar as unconjugated hyperbilirubinemia, okay? So Crigler-Nahar, this is a decreased activity of glucuronyltransferase, so you have a very high unconjugated bili, and that's because of the absence activity that's there. So Gilbert's and Crigler-Nahar unconjugated, and then think of Dr. C, DR, period C, Dubin-Johnson and Rotors are for the conjugated. So here's that liver that we were talking about. So here's the unconjugated bilirubin, and that's bound to albumin. Then it gets linked up with ligandin. Here are your unconjugated bilirubin, and then that at this UGT1A1 is where Gilbert's and Crigler-Nahar is going to be really effective. And then at this point is at the conjugated when it gets excreted out into the apical surface. It's the MRP2 is where Dubin-Johnson's. You do not need to bind yourself to all these different UGT1A1 or MRP2. Just know that Gilbert's and Crigler-Nahar unconjugated bilirubinemia, enzymatic defects, and Dubin-Johnson Rotor are conjugated, you'll be okay. all right? So conjugation disorders, most prevalent, this is the UDPGT1A1, Gilbert's, Crigler-Najjar, type 1, type 2. Again, I wouldn't stress yourself about Araya syndrome or such. Know that Gilbert's is very common in about 5 to 10% of the population. And these are adults that can get jaundice when they get stressed out, and their levels will climb enough, they'll cause yellowing in their eyes, and then it goes away. Okay, the Crigler-Najjars are more lethal and more of a problem, but rarely seen, thankfully. The enterohepatic recirculation, then 25% is excreted. The bilirubin is reabsorbed, unconjugated. So that beta glucuronidase that we talked about is variable amounts in the BM. And so here's that beta, the bilirubin diglucuronide breaks down to bilirubin, to urobilinogen, to stercobilinogen, and then it's oxidized stercobilinogen that gives you that brown feces color. And so it's converting it over into a water-soluble form. It's exactly what the phototherapy light is doing. And so when we do onset, the first day, if you have, in the first 24 hours of life, if that bilirubin is greater than usually 6, we consider that pathologic. That there's a problem that's ongoing with that bilirubin, and that's causing it to be an issue. Remember, bilirubin is a feature of both time and number. So just because you have a level, it really depends on how many hours of life, because as you go further along the way, you are able to tolerate a little bit higher and higher bilirubin levels. The nomograms that exist, particularly the Butani curve, are only designed for infants that are greater than 35 weeks gestation. So even though we extrapolate it and however we want to use it, you really can't use that nomogram for the 28-weeker or the 30-weeker. It's completely incorrect to use it in that way. So after the first week, we worry about infection, inborn errors. If it's prolonged, there's the breast milk jaundice. Remember, this is typically on the boards of the infant who hasn't had prenatal care, who comes to your office at about 2 to 3 weeks of life and has a high bilirubin. And it's just that mom's breast milk is causing that jaundice to be there. Genetic, drug-mediated, and hemolytic. So evaluation is really kind of an interpretation of the results in postnatal hours. You can't determine level by exam. Again, you can't look at the baby and says, he's about a 12, and that one's about a 6. You're going to get completely in trouble that way, all right? So first measure is total and direct bilirubin. The direct, what causes high direct bilirubin? Torch, thank you. Torch, okay? So do you see direct hyperbilirubinemia? Think torch infections. But the other part about direct, all the gut stuff. So biliary atresia, colodocal cysts, inborn errors of metabolism should then kind of filter in as the rest of your differential. CBC, retic count, peripheral spare, blood type, and Coombs. Treatment, and the reason why we do anything is that indirect hyperbilirubinemia, remember the free guys that are just partying around? They go to the brain and cause issues, and that can cause staining into the basal ganglia space and cause problems of kernicterus. So we start phototherapy, intensive phototherapy. It uses a product of lumirubin, which is water soluble. There's an optimal wavelength, about 460 nanometers, and so you can kind of see where the light sources are. We kind of inundate the baby, protect their eyes with a little blindfold, and get them a little like a suntan. And so they get usually from a wallaby blanket from below, a neo-blue light from above, whatever you need to kind of increase surface area and exposure. You get them down to their skimpies and allow them to get as much light therapy as possible. So complications, that's why we cover the eyes. They can have some water loss. You want to make sure that they're not getting dehydrated. And if you are not sure if you're treating unconjugated or conjugated, if the direct hyperbilirubinemia is high and the indirect is not high and you give light, you're going to cause the baby to be bronzed, okay? And so this is why it's really, really important to figure out, are we dealing with the indirect component? Because the levels you're going to send is a total bilirubin. You get a total and you're going to get a direct. The difference of that is going to be your indirect. So you have to make sure that the direct is not super high, that is causing your indirect to be a lower amount that does not require phototherapy. All right? This is the Butani curve. Great curve, again, used for 35 weeks or greater. The other caveat is once you go on phototherapy, the Butani curve is not effective then. I have, my students will tell me after we've gone on phototherapy and we've come off, we're now at 140 hours of life and it's a low intermediate risk. No,
We're not anything now at this point. Once you're on this is just to help you determine if you need to get on the curve, if you need to get on the lights. It's a screening device. Afterwards, Dr. Butani did not mean it to be used for forever afterwards. So once you're on phototherapy, the curve does not help you at all then. Treatments, IVIG has become more and more in favor. There's a nice paper here in 2014 of using it, particularly in kids that have ABO incompatibility. You give one dose of IVIG and usually kind of keeps it under control. Exchange transfusion is kind of the next line of therapy. We try not to do it because of all the complications, but I've still done it. Maybe once a year we'll do an exchange. The complications include acidosis, thrombocytopenia, and so we really want to make sure that that's not a problem. We always worry about thrombosis and necrotizing enterocolitis. Finally, erythroblastosis fetalis and hemolytic disease. This is looking at Rh antigens and the minor antigens. They can cause sensitization and variable with each pregnancy. RhoGAM is given at 28 weeks gestation and within 72 hours of birth. High-risk neonates is looking at those that have the transfusion, high drops, low hematocrit, or Coombs test. The reason why we care about any of this is kernicterus. Remember, it's very rare. It's a huge problem. There's no set number that determines kernicterus. It's not that if you're a 22 or a 24 or a 30 bilirubin level that causes kernicterus. Usually the infant will have increased tone, some posturing, some abnormal ABR eye movement. They can have staining in the primary basal ganglia, abnormal tone, hearing defects, kind of that upward gaze, very shrill, high-pitched cry, dental enamel dysplasia. Thankfully, it's less and less seen, but it is still there and is a huge medical legal risk, so be very, very careful. All right, I think that's the last question. Neonatal jaundice is always physiologic in the first days of life, can be accurately estimated via physical exam. C is associated with long-term sequelae only if exceeding 25, or D must be evaluated in association with postnatal age. Perfect, very good. So, just quick things, make sure you get rest, pace yourself on the exam, really don't get caught up on too many of the questions. If you miss it, if you don't know it, move on. There'll probably be better questions that moving forward, and just kind of mark your question. Really make sure that you read the vignettes. The boards puts things in their vignettes for a reason, typically like the sex of the baby or the gestational age makes a huge difference. Really don't infer things that aren't necessarily on the examination. Complete your blocks of questions and make sure you take breaks. Don't chug through like 4 or 5 blocks in a row. And really, honestly, you guys are putting a lot of time and effort into preparing. Make sure you get some rest. So study hard, and the last week or so, really kind of just review. Make sure you get a good night's sleep. Don't go cramming into that examination, and best of luck. It was a pleasure teaching you.